Hi, sir. Dr. Gupta, Dr. Shenoy, hi. So you're muted. Dr. Shenoy, you're muted.
Okay, I just get myself done.
Yeah. I can hear you.
You can hear me?
Yeah. How are you?
Hi, sir.
Fine, back at Bangalore.
Hi, Dr.
Back
Gupta.
at Bangalore.
Hi.
Yeah.
Hi, Prathmesh. I think today third day.
Pawan?
Yeah.
Yeah. Great to meet you.
Thanks, Dr. Srinay, and my apologies. I should have connected with you earlier, but
Oh, not at all.
and I'm sure we will remain connected. And we will. This Oral Oncology Connect program is mainly for joining everyone, all the seniors, and trying to dissipate the knowledge and getting other people into it. So that's the capacity building that we are trying to do. So,
I'm
Fine. This has to, yeah. I'm getting there.
You're muted.
Am I muted?
No, not you. Dr.
Mudit.
Mudit is muted.
Hello, Dr. Srinay. Hello, sir. Hi, Prathmesh.
hi, Mudit.
Hi.
Hi, Prathmesh.
Rishabh.
Good evening.
Yeah, hi, Dina.
Good evening.
Good evening, Prathamesh sir. Good evening, Ashok sir. Good evening, Dina ma'am.
Hi, Rishabh. Good evening.
Hi, Rishabh.
I think my video.
Hi, Rashi.
Yeah.
Good evening, everyone.
Rishabh, where is the final final presentation? You have it or?
As usual, you have an anatomical stage.
WhatsApp, the final presentation.
In that group, I'm not able to get in the group. Either you put it in the PSR or in the common group, because that I'm not connected to that group.
Chapters. Somebody who has an N2 disease anatomically would fall into stage 3. But N2 disease.
Hi, Dr. Rashi. How are you?
बढ़िया है मुझे आप कैसे हैं
बस सब सही
Clinically
डॉक्टर पवन के प्रोग्राम की वजह से आपसे मिल रही है
This has is basically for guiding
Which one?
not for
Okay.
selecting if you are.
Okay, one second. What's the program like? The program below.
So while we have got just 2 to 3 minutes, I'll just share one of the video that we launched last time. I'll just share the screen and get into that video, and just for everyone to have a look.
Number 2. Kilo. Another first one. Okay.
So that was the Triscare that we have launched for the mouth opening device.
Very nice.
How much does it cost?
Just 850 for the patient.
Okay, that's good. Where is it available?
It's available through ICanCaRe, and
Okay.
we are trying to make it available across India wherever it is possible.
Okay.
However,
Okay.
so
Okay.
Shruti and Rishabh, they will make sure that it reaches you.
Yeah, other people are also sucking varieties of it. The most expensive is probably Terabyte. And the less expensive ones are Orabyte, which is done by Dina people, sold across the country. The same people
That is also 3,000 rupees.
Yeah, that's what. 850 is much better. That's what I'm saying.
850 is absolutely simple and easy to use.
Okay, that's good.
Hi, Arjun.
Afternoon, sir.
You're looking dapper.
Thank you, sir.
Dr. Shenoy, Arjun is our budding maxillofacial surgeon who's head over, in research, and he writes, an article a day.
Oh, wow. And where is he based?
He's at Tata Hospital currently.
Okay. So he is a protege.
He is Dr. Pankaj Chatuvedi's protege.
Okay.
And he's going to take off after him.
Yes, sir, please.
Good.
Pratmesh, I'm seeing you after ages, actually.
Long time, sir.
Long time. Last time I saw you at Madras.
Yeah.
I just had my,
Yeah.
And after that, it's been a series of onlines, except last week, I think I met Mudit and all at
right.
Lucknow. Lucknow was a ISO meeting.
Yes, sir.
They're planning something really big in Bombay. Your senior ex-Tata guys. ICC, yeah. So they are having it at the Ambani's Plush Center at Bandra somewhere.
Yeah.
And it's 10,000. Yeah, that's where they are planning to have it.
That's a mega place. So
yeah,
it surely can accommodate a lot of people.
Yeah, 10,000 is what they say. So I don't know.
Till now, Renaissance was the biggest place in Bombay.
Yeah.
But I think this is going to be the biggest. So our limitations used to be 5,000 and odd. Yeah. So this is going to really double.
Double. I've told them that we would like to be a part of the partners from the foundation group. So I have told Toprani is now the ISO president, Rajendra Toprani.
Yeah.
So I conveyed to him, I think we should take it up from there. And
yeah, we will. We have always partnered with them. So I'm sure this year as well we will do it.
No, but right now we are not a partner. We are not there. We are not there. So I think I have told them that we would like to partner so that we will get some good international speakers at no cost. So that should be there. But their thing is that we should have a big representation from the head and neck group who will register. That's their, they want it that way. So I told them, you first advertise it and I'll make sure that you will get a lot of boys because this is our #1 cancer, whether you like it or not, everybody has to be interested. I mean, whether you're doing part-time head and neck or full-time head and neck, you need to be involved. You need to know the subject. So let's hope.
I'm sure we'll be able to do it.
Yeah.
And this is going to be one mega unit, mega event, following COVID. So I'm sure a lot of people will attend it.
Yeah, provided COVID doesn't relapse. In Shanghai, it's a very big scene, If you see the CNN and all, it's really sad. One is worried.
I think Rishabh, please share and start. People are joining in, and welcome Shomesh Bhai. Then we have got Vani is also there. So many others have also joined. So welcome, and let's start. Let's start the proceedings.
Hi,
Yeah.
Vani.
Hi. Thank you for inviting.
Yeah, thank you very much for conducting everything. We are grateful to Pawan.
Thank you so much, sir. With your permission, let me begin today's program. A very warm good evening to the esteemed guests, faculty members, and the participating doctors on Facebook, YouTube, and Zoom Live for joining on the third day for the Oral Awareness Month, which where ICanCaRe along with the Foundation for Head and Neck Oncology, Sterling Cancer Hospital, and Gujarat University, conducting this ICanCaRe second International Oral Cancer E-Conclave. So a very warm welcome to everyone to this third day of scientific session, where it is theme-based, where we are doing the restorative approaches for oral cancers. And along the late in the evening, we'll also be having the quiz and exciting prizes for the participating members here. I would like to extend my gratitude to the organizing members, organizing team, and the different organizations who have come together to put forth this wonderful e-conclave for the entire month of April. And we look forward to more such participation as well. So and extend my greetings and thanks to all the participating organizations. Just to make note of these of the e-conclave, please keep your microphones on mute mode, and even if you have any questions, do raise your hand or put your questions on the chat box. Our moderators as well will get back to you, and the faculty members will definitely answer to your queries. And so put all your questions on the chat box. There's a small set of warnings as provided by the Government of India that this whole program is being monitored and as well as being recorded. So any abusive or obscene language is being for disrupting the program will be dealt with stringent laws and actions will be taken. So please make sure that to maintain the decorum of this e-conclave program. Thank you so much. With this, I like to invite the moderator for the entire scientific session of today, Dr. Kush Shah. Dr. Kush Shah is MS and DRNB of surgical oncology. He's a surgical oncologist with more than 3 years of experience in managing basic to complex oncological cases, specialized interest in advanced head and neck, thoracic and gynecological oncology cases, and preventive measures against cancer and awareness. He has international observation in head and neck oncology from the reputed Memorial Sloan Kettering Cancer Center, New York, USA, under Dr. Jatin Shah and Dr. Ashok Shah. Performed and assisted various basic and advanced surgical oncology procedures. With excellent communication skills, is able to deal with patients and their attendees as well as with the work colleagues, ethically compliant with the medical code of conduct. So I now invite Dr. Kush Shah to take this entire session forward.
Hello. Yeah. Good evening, everyone. I welcome everyone to the third session of this ICanCaRe oral oncology sessions. I congratulate Dr. Pawan sir and the entire ICanCaRe team for organizing these 4 sessions of oral oncology capacity building for oral cancers over the 4 weekends of this April month. So today's topic is the restorative approaches for the oral cancer. We must, no doubt, oncological clearance precedes everything, but we must agree that restoration of form as well as function is as important as oncological clearance. For that, we should work in conjunction with our reconstruction and rehabilitation team, pre-operatively, intra-op and post-operatively, to give the maximum benefit related to form and function to our oral cancer patients. Without wasting much time, I would like to welcome the moderator the screen?
Okay.
Rishabh, please share the screen.
Yes. So I'd like to welcome Dr. Rashi Agarwal ma'am, who is clinical and radiation oncologist working at the Max Healthcare. She has done her radiation oncology training from GSPM Medical College, Kanpur. She has been awarded international fellowship by UICC and also Tata Memorial Hospital. She has been trained in delivering precise and accurate.
Oh my God.
Using IDRT, IMRT, image guided brachytherapy, and in CyberKnife, and she has been trained in USA also. So I'd like to welcome Dr. Rashi Agarwal ma'am and to carry forward the further scientific session.
Thank you so much, Dr. Kush.
Damn, you didn't tell me she was hot.
First of all, I would like to thank Dr. Pawan Gupta and his team for organizing such a nice conference. And today's topic is local surgical procedures for oral cancer. And without wasting any time, I would like to invite chairperson of the session, Dr. Manoj Jauhar. Dr. Manoj Jauhar is MCH Plastic Surgery from CMC Ludhiana. And he is head of the department, senior director of Max Super Specialty Hospital, Vaishali and Papaganj. And he is also director and promoter Academy for International Career and Education. So welcome, Dr. Manoj Jauhar. And for talk on local surgical procedures for oral cancer, I would like to invite Dr. Mudit Agrawal. Dr. Mudit Agrawal is senior consultant and head and neck surgical oncology in Rajiv Gandhi Cancer Institute, Delhi. And he is specialized in, I think, every head and neck surgery. And being radiation oncologist, it's my proud privilege to invite him for his talk and to hear from him. Welcome, Dr. Mudit.
Thank you, Dr. Rashi. And Dr. Manoj Jauhar, hello, how are you? Long time.
How are you? Nice to meet you again on this platform.
Yeah. Yes, sir. So I will share my screen, sir. I think in this talk, I will require your input because it's about the reconstruction. It's a difficult topic. I am just giving forward what I believe and what I do. I might be right, I might not be right. So all the senior fellows, Dr. Shinoy, Dr. Patnesh, they will have him because the practice which we do it also depends on that.
Yeah.
So I will be talking about the local surgical procedures for oral cancer, when to consider reconstruction oral early lesions. So I will just briefly tell you about the factors which we need to consider while reconstructing oral cavity defect. So we are talking first of all of early defects. So defects means we have to see the location and what's the function of the organ and the size of the defect. And the flap, what we are going to use, should be reliable, functional, cosmetically acceptable, and of suitable size. And then one should match the recipient size, color, texture. And then after that, what we need to do is we have to see that minimal donor site mobility should be there. So defect, now we go to the subsite of oral cavity. So in buccal mucosa, usually I feel that if a small lesion is, or if you say 5 mm lesion is there or 6 mm lesion is there, you take a centimeter margin all around, you will need, most of the time you will require to need a reconstruction. What reconstruction? We'll go into it. So it needs a reconstruction. Otherwise, and most of our patients who are having already OSMF, they will require it because the defect what you create will be much larger than what you anticipate. For tongue lesions, for floor of mouth, alveolus, and palate and lip. So I'll be concentrating on that. So there are various loco-regional options present for T1, T2 lesions. One is submental flap, which is being very commonly used, but only thing we have to take care that it should be N0 patients. And if we suspect any node during surgery or during that, we need to abandon this procedure. Other flaps which can use are oncologically safe is infrared flap, which is based on superior thyroid artery, FAM flap, facial artery, musculoskeletal flap, supraclavicular flap, which is based on the supraclavicular branch of transverse cervical artery, And other flaps which we have ourselves devised is modified submental pedicimal adipomyfacial flap. And the workhorse which we know of is a PMC flap. So other what local regional options can be there for palatal defects is a temporalis flap, which is based on the maxillary artery, deep branch of maxillary artery, and temporal palatal flap, which is based on superficial temporal artery. Nasal flap, it could be based on the labial artery of the facial artery, the labial branch of the facial artery, or it could be a random one also. Other flap which we have used is modified lateral trapezius flap, which is based on transverse cervical vessels. And rarely we have used buccal pad of fat, but can be used in conjunction with other flaps. Deltopectoral flap, usually in early lesions, you will not use it. Skin grafting, people use it, but I don't prefer it. Operator can be one of the options if we are doing an alveolar defect, and primary closure can be done. So other option which you can use is a free flap, where Dr. Johar mostly does it. And so now coming to Anseren classification, how they did it. If you see the type 1 glossectomy, means you have removed the mucosa. You can see in this figure mucosa and some of the interesting muscle. You can just leave it raw, or you can just close it primarily. Now coming to type 2 defects of glossectomy, when you are removing the mucosa as well as intrinsic muscles, but you're not crossing. So these defects, you can leave it raw or partially close them. The type 3 defects which are there, where you are reaching up to the midline and you're doing the extrinsic muscle as well, or you're crossing the line, then these needs to be reconstructed. The options which we have, as I just enumerated, the infrared muscle flap can be used, or infrared with skin you can use, PAM flap, modified Spaff flap, infrahead flap, supraclavicular, modified lateral trapezius, and definitely microvascular free flaps are always there. But I will be sticking myself to the local region, because in private practice, cost becomes a really problem. But talking science, it might not fit there. But in practical, if you see, the most of the work, 60% of the work would be local regional, and 40% we will be doing a free flaps. So now coming to that, for tongue, for T1, T2 lesion, if you feel the defect size, if the tongue volume is around 70% remaining, less than 30% of it is remained, then in posterior lateral border of tongue, then you can leave it raw, you can primarily close it, and one thing one should take care of it is avoid tip rotation. Middle, third lateral border of tongue, same principle is there. Please don't, when you're doing a prime closure, don't avoid the tip rotation. And resection, when it's involving the tip, or if you are resecting the tip, then that needs reconstruction. So various forms of flaps we can use it. So one of the examples I will show you is a small lesion, T1 lesion on the lateral border of tongue. So you take a 1 centimeter margin all around. This is the defect. So if you try to primarily close it, that tongue will get rotated fully. So what you do is just partially close it and leave the tongue raw. So the danger of that, you might feel that you might have a secondary hemorrhage because of that. So routinely, as we have learned from the TORS, that lingual artery, we almost always lag it in a partial vasectomy, where we are leaving it raw. So these things will prevent any devastating hemorrhage which can occur in post-op time. So one of the patient whom we had done a partial resection and a primary closure. So infrahead flap for the tongue defects. So this is based on the superior thyroid artery. You can take it from the neck here, and depending on the defect, you can take the amount of skin. So the width is a problem here. Width, you can take maximum what you can pinch is a 4 centimeter, but you can extend it also. We have done a large infrared flap also. You can extend it also, but because we are talking about small defect, you can use this flap, and it's based on superior thyroid. No oncological compromise here, and you can use this flap for reconstruction. So this is one of our patient whom we did an infrahead flap. You can see the tongue mobility.
बोलने में कोई परेशानी बोलने में अभी बोल रहा हूँ ठीक
So we had take a larger flap. Around width of this flap was around 4.5 centimeter, but we could achieve primary closure of the neck. Otherwise, we would have used a adjacent flap for reconstruction. So other flap which I was talking about is modified Spaff flap. This is basically a submental flap, but for males, what happens that because of hair growth, you can't use this flap, because that will cause, because most early cases, they will not require adjuvant radiation, and hair will be definitely a problem. So what we thought of it, why not go for technique like this? So you can use it for small, medium-sized defect. You will not require any deepthalization or laser epilation when we do this procedure. So we can use it in combination. We published this in our European archives. So just example of, so this is a tongue and floor mouth defect. So what we do is it's an N0 lesion, as I told, the indications are same. So we raise a supraplatysmal flap here of the skin. So, and the platysma is taken along with, then we raise a submental flap based on the submental branch of the facial artery. And then we take along with it antibilateral digastric and the myaloid muscle to give the bulk of it. So in that, you can rotate this flap through the floor of mouth and just reconstruct the defect. So this flap can be used for many other defects also. So supraclavicular flap is one of the flaps which we use it. And Dr. Shenoy also have a large series of using supraclavicular flap from Kidwai. So this is a little bit of like a type 3 defect is there. So what you do is you reconstruct, you can see that it is based on the supraclavicular branch of the transverse cervical artery. So you can tunnel it through the floor mouth and use it. And the other problem with this flap is it will be like a band. So after a few months, you can divide this. So patient will have a good outcome. So other flap which we have used is, which we publish is modified lateral trapezius flap for tongue defects. So this is similar to supraclavicular flap, but it is based not on supraclavicular artery, it is based on the transverse cervical vessels only. And you have to cut, I land it on the trapezius muscle, where the transverse cervical, your spinal series enters into the trapezius muscle. So this flap, you can use it. So this also gives us a good reconstruction for tongue as well as for floor mouth reconstruction. So other flap which are people from South, Dr. Joseph uses, is a FAM flap. This flap will not give you bulk majorly, but it will give a good cover. But one has to be cautious because our patients mostly are tobacco chewers, will be having submucous fibrosis. So it's not ideal flap for these patients. Otherwise, it is a good flap. So now coming to partial ostectomy defect with fluoromouth defect is there. Then if posteriorly located, we have to see whether orocervical communication is there or not. If orocervical communication is there, then we need to reconstruct these flaps, this area. And if we find no orocervical communication, but we are very not sure, especially in glossotonsillar area posteriorly where it's very thin, that we might have to augment by using a anterior belly of sternomastoid or a submental gland itself if you have spared them. Or mid-anterior defect we usually used to need to reconstruct. So for buttressing, we have used a omoid flap. If you are feeling that if it's because if omoid is bulky, you can use this muscle, or otherwise you can use the anterior belly of sternomastoid flap for reconstructing. Dr. Alok Thakur has published it for TORS patients. So this is one of our patients whom we had a marginal mandibulectomy and a floor mouth resection, and infrared flap has been reconstructed. So what other thing we are doing it, that because that muscle only flap of the infrahead cannot be taken. We take a platysma, we leave the skin there, and this we preserve the ansa cervicalis, and this all the strap muscles based on superior thyroid vessels can be brought into the floor mouth very easily and can be used to contour the tongue defect. So you can use a supraclavicular flap for the floor mouth defect as well. You can see it here. So now coming to defects like tongue, floor mouth, and we have done a marginal mandibulectomy. So we need to cover the bone. So for these, reconstruction is required. So one of the patient where we had done a submental platysma flap without skin. We have done this marginal mandibulectomy, floor mouth excision, bilateral neck we have done, and this flap is raised and this is put here. You can see it, and on follow-up, patient didn't go for any radiation therapy. It was an early lesion, and this is the follow-up, and no scar you can see virtually. So this is a good flap one can use in certain indications. So buccal mucosa defect, as I told you, in posterior small defects, you can use a buccal pad of fat, but it induces fibrosis, so it's not a great choice. But other flaps which I mentioned can be used for buccal mucosa. And buccal mucosa with RMT, definitely we need to reconstruct them. And if you have done it with upper areolectomy as well, where there is a breach in maxillary floor, then we need to reconstruct we need to use a flap which has a good reach. So pectoralis major myoclonus flap can also be one of the options in these patients. So in this one of the patients whom we had done a marginal mandibulectomy, you can see a T1, T2 bordering lesion, marginal mandibulectomy has been done, and we have not breached upper areolus has not been breached. So we have used a submental platysma flap. So he is just on follow-up since 3-4 years. But we have to advise that they should go for the use mouth devices for opening, mouth opening exercises needs to be done for these patients. So similar SMAF flap for buccal mucosa, early lesion on follow. That's it. Another patient we have undergone buccal mucosa resection plus marginal mandibulectomy. So the thing is, if you use a typical submental flap and you don't give radiation to these patients, then definitely it will be a problem. Hair growth will be there. So we had done a traditional submental flap, but because the patient got radiation, so we got away with this problem. Otherwise, it's a terrible problem. So for typical buccal mucosa defect, this is otherwise would have required a RAF. So what if we did was a lateral trapezius flap based on transverse cervical vessels. So you can see here, it's and the skin which you are seeing is a deepthalized skin we have put as a graft on this side. We have not harvested any skin from there. So this article we published in European archives as well, and we have used for postopharyngeal wall defects also, tongue defects also we have used it. So we can use combination of these locations. Like if you see a defect which is there here in the buccal mucosa, you've done a marginal anatomy, and you have a defect in the upper alveolus as well as here in the in the anterior tonsil, you're reaching up to it. And then after that, you can reconstruct this. We have done a transverse oriented infrared flap we have used along with submental platysmal flap. And you can see posteriorly we have put a submental flap because reach of this flap is very good as compared to this infrared flap. So it is used for buccal mucosa, and posteriorly we have placed this. So now for buccal mucosa defect, typical T1, T2 lesion, no radiation required. So supraclavian flap has been used. So we can use it for lip and buccal mucosa defect combination. Supraclavian flap has been used. You can turn it and you can use it. So now another patient of buccal mucosa plus lip. So you just resect this, and this was a defect with marginal mandibulectomy we had done. So what we have used is the supraclavian flap for inner lining, and outer cover what we used was a transverse, only the skin with platysma of the cervical lesion wherever you raise it, and you just approximate on the outer area. So you can use the combination of flaps. So another GT circus lesion, we had done a marginal mandibulectomy via local excision of the buccal mucosa, and we reconstructed the buccal mucosa and tonsillar area with this supraclavian flap, and bone was covered with a submental platysmal flap. So these are the post-op outcomes. So another patient of buccal mucosa with angle of mouth, and we resected the lip. In fact, you can see it here. And we use a nasolabial for outer cover and the lip reconstruction. And inside we use submental platysmal flap. So another which I'm not using it now sparingly, we are using it. The platysma with skin, you can use it based on extrajugular and branch of facial artery. We need to preserve it, and you can use it for reconstruction of a small buccal mucosa defect. So this is a tongue flap. I don't prefer it. Only this was a very cardiologically high-risk patient and a small lesion. So we use a tongue flap and for this patient. Otherwise, tongue flap we usually don't prefer. You can use for small RMT lesions. You can use a master flap as well. But problem is that trismus will be there. So patient needs to be advised that they need to do a good mouth opening exercise post-operatively. So palatal defects also require reconstruction if you have a bone defect. Otherwise, you can leave them raw, or you can use a buccal pad of fat also. So options for maxillary entry is obturator. You can use an obturator. You can use nasal flap, palatal flap, temporis flap is commonly used, and you can use a temporopalatal facial flap as well. So we have used for this, you can see the defect there, upper alveolus and maxilla, portion of maxilla has been removed. You can use this submental platysmal flap for reconstruction of these defect as well. And for this patient, he had already operated outside. We resected the mucosa here, and the soft palate was resected. So we use this remaining mucosa based on greater palatine and covered the soft palate defect, and rest was granulating by itself. So palatal flaps can be used based on greater palatine. And lip defects less than 1/3, you can close it primarily, or you can do bilateral advancement. But if more than 1/3 or 2/3, we have other options: Aviza slender, claropanzic, nasolabial submental flap, modified Spaff, supraclavicular. You can use various kind of flaps. So what we have used for this patient, I will tell you, that is it's a buccal mucosa defect, and the whole of the lip has gone. So we have used submental flap inside, and we have supplemented it with nasolabial flap. So this is another lesion, early lesion of the lip, but skin was not, because already operated somewhere, biopsy was done. So we removed the skin, and you can see we had used a submental flap only, and then we had put this flap. and inside we had put a skin graft over the muscle area. So buccal pad of fat can be used, small posterior defects, you can use it. So split thickness graft have been described, but we don't use it. But anti-floral mouth, they found that its quality of life is not good and worse chewing in one of the articles by Larson. So to conclude, I will say for early buccal mucosal defect will require a flap reconstruction. Primary closure can be attained if less than 30% of the volume tongue defect is there, or you can leave it raw. More than 30% will require reconstruction. If floral mouth breach is there or orocervical communication there, we require a flap reconstruction, especially GT circulus lesion. If we are doing a marginal mandibulectomy, we require a flap reconstruction. Otherwise, for palatal bone breach is there, then we will require a reconstruction, or operator can be used. For lip defect, which are larger, will also require free flap reconstruction. Thank you. Thank you. Yeah.
Excellent. I think Dr. Mudit, you've done a fantastic job, covered the whole topic beautifully, given us so many options with exemplary examples, clinical cases, etc. You were always, I think, more of a plastic surgeon than an oncosurgeon. And whatever short period we worked for, you did shape our thinking for flap reconstruction. So yes, you're right that 60% of it can be done under with these loco-regional flaps. However, I think it depends on practice to practice. And the kind of cases that we see, we are normally seeing more and more secondary cases or little late cases and things like that. So in that, the options do get limited. So just a couple of points, rightly so. Cost is a factor, and functional outcome today is probably the leading guideline for the objective of reconstruction. So it's not just about cover, it's not just about getting the wound to be closing. I think it's a functional outcome which is paramount. So in those contexts, there are multiple factors other than cost as well. You know that better than we do. There's paucity of tissue. There are other comorbidities.
So I think flap is the, we know that it is one of the, see, we bank on flaps all the time. But sometimes it happens that we have, the patient is high risk or something is there, or in our private sector, cost becomes so we choose other options. So that's why how we developed over a period of time.
Correct.
How can we go for local regional? Because PMC cannot be answered for small defects.
Yes.
So you need to have flaps which are thinner, which can be used.
Correct.
But we have to see oncological safety of the procedure, what we are doing. So that we have to see into context, and then we have to plan for it.
Yeah. So I guess if case selection is done judicially and one is adept with the different knowledge of different flaps, it's very regular, normal to be able to use these options. However, 2 pointers. Number one, we are seeing a lot of secondary and tertiary recurrences, and so the fact that local options have been used up or compromised your tissues locally do add to a little surgical challenge later on. That is on one side. On the other side, now there is a lot of development happening on perforator flaps. So, for example, there are multiple perforator flaps based on radial artery itself. So one doesn't have to take a complete radial artery forearm flap as we know it traditionally. You can start raising smaller or finer on minor branches, which are perforator flaps. And so it sort of gives you a little bit more choice in terms of volume of tissue, adaptability of tissue, going to a further region without compromising also. These two factors can be taken into consideration when reconstruction is being planned. But other than that, I think what you have presented is fantastic.
Thank you, sir.
My compliments.
Yeah, thank you, sir.
Yeah, thank you, Dr. Munit and Dr. Manoj. Your talk was excellent and excellent discussion, sir. So moving towards our next session, next talk, I would like to invite Dr. Ashok Shunai. Dr. Ashok Shunai is Professor in Hand in Department of Head and Neck Surgery, Kidwai Memorial Institute of Oncology, Bangalore. And as a speaker, I would like to invite Dr. Richa Vash. She is Assistant Professor in Department of Head and Neck in TMH, Mumbai. And her topic of talk is Sentinel Node Biopsy. So over to you, Dr. Richa, and over to you, sir, Dr. Ashok Mohan Shunai, sir.
Yeah. Firstly, let me introduce myself. I'm no longer with the Kidwai Memorial. I have retired. I was at Patna last 2 years at the Mahavir Cancer Samsthan. I've finished that 2-year tenure and I'm back in Bangalore. And I know Richa well, and I would, without much further ado, let's hear a talk, and then we will discuss it from that point. So Richa, please start your talk, give a bit of history, tell us how it has progressed and where it stands today. Richa, over to you.
Sure. Thank you so much, sir. I'll just share my screen. Okay, it shows to me that host has disabled the participant screen sharing. So if it could be enabled, I'll start sharing the screen.
Please. Please.
Please go ahead, ma'am. Please share your screen.
Go ahead.
Okay, I hope my screen is visible now.
Yeah.
And I'm audible. Okay, so at the outset of my presentation, I would like to thank the organizing committee for giving me this opportunity, and I'm going to talk about the Sentinel Node biopsy in oral cancer. Now, elective neck dissection is a standard of care today in all node-negative early oral cancer, and this was well borne out from a big trial from Tata Memorial Hospital, where we showed that 8 elective neck dissection done save 1 life, and 4 elective neck dissection done prevent 1 recurrence. But there is also a problematic side to it. About 55 to 70% of the node-negative patients are actually truly node-negative, and doing the elective neck dissection in those patients is a over-treatment. And the neck dissection is associated with the morbidity, which is mainly in terms of the nerve damage. So this is the data from the SENT trial by Ian Hutchison, which shows that the incidence of nerve damage can be as high as 40% even in elective neck dissection, and nearly 5% of which can actually be very disabling. So in the past, multiple attempts have been made to identify the true node-negative patients through various imaging modality, ultrasound, CT scan, PET scan, but everything has a very low sensitivity ranging from about 50 to 66%, and therefore this option was not a very feasible option. Attempts were also extended with gene expression and various molecular markers, but again, a very low predictive value of about 72% and high chance of missing the disease. So this also didn't work out. Now, sentinel node biopsy is a very well-established concept in melanoma and breast cancer, and for the past decade, it has been explored a lot in early node-negative oral cancer. Now, what's a sentinel node? The concept says that spread of the tumor is embolic in nature via the lymphatics to the first echelon lymph node encountered in the regional draining basin. So this is a node that is most likely to harbor the metastasis. And if this node doesn't have the metastasis, then that neck is truly node negative, and probably the neck dissection can be spared in those patients. This concept was first explored a long time back in 2010 by Siventos, and they had operated upon 106 node negative patient, of which sentinel node negative patient, on performing the completion neck dissection, 100 of which were truly node negative. So the negative predictive value in the study was 94%, and this improved to 96% with serial subsectioning and immunohistochemistry. Since then, multiple meta-analyses have been published establishing the diagnostic accuracy of sentinel node biopsy. But the data was lacking on the therapeutic efficacy. And the first time it was provided by the SENT trial when they published a 3 years outcome of 415 patients recruited over 14 centers in Europe. They showed that in addition to the high negative predictive value of 95%, this also has a very high disease-specific survival of 94%, and that established the therapeutic efficacy of the sentinel node biopsy in early oral cancer. But what was lacking in the literature was a head-on comparison with the elective neck dissection. And recently we have seen in quick succession publication of 2 large randomized control trial in JCO. First of which was a French trial by Garel et al., which was an equivalence randomized trial to compare the treatment based on the sentinel node navigated neck dissection and the elective neck dissection in T1, T2, N0 oral and oropharyngeal cancer. Now this was a centimaroral trial, and the aim of this trial was to establish the equivalence of sentinel node biopsy and neck dissection, comparing the 2 years neck node recurrence-free survival. It also looked at the functional outcome in these patients. So this is quickly to explain the trial schema. T1, T2, N0 oral and oropharyngeal cancers were randomized either to the elective neck dissection arm or to the sentinel node biopsy arm. Patients who underwent sentinel node biopsy were subjected to frozen section, and if the node was positive, then a completion neck dissection was performed in the same sitting. But if the node was negative, a further serial step sectioning and a immunohistochemistry was done. And if the node was negative, in those cases, a neck was spared. And if the node was positive, then a second stage completion neck dissection was performed. Now, this trial accrued 307 patients. However, 28 were excluded because of the lack of invasion on the biopsy. And therefore, 279 patients were finally analyzed, 139 in the neck dissection arm and 140 in the sentinel node arm. The mean follow-up was around 5 years. And when they looked at the neck regional recurrence in the node negative neck in the elective neck dissection arm, it was 11. That is 10.1% of the patients still had a regional recurrence after the elective neck dissection being reported pathologically node negative, and 8.1% when the sentinel node was negative, still the patients had the recurrence, and there was no significant difference in the two values. When they looked at the overall survival in terms of the 2 years neck node recurrence-free survival, here we see the curves that are totally overlapping with the recurrence-free survival of 89.6% in the neck dissection arm and 90.7% in the sentinel node arm, which established confirmed the hypothesis that was proposed by the authors. The survival was also similar in terms of locoregional recurrence-free survival, disease-specific survival, and overall survival with completely overlapping curve. So this established the oncologic safety of the sentinel node biopsy. Coming on to the functional outcomes following the sentinel node biopsy, the median and the mean hospital stay was longer in neck dissection arm compared to sentinel node arm, and this difference was statistically significant. When they compared the number of physiotherapy prescription issued at 2 months, 4 months, and 6 months, the rate was significantly higher in the neck dissection arm compared to the sentinel node arm. But we observed that at 12 and 24 months, the issue rate was similar. Now, this is a radar plot that reports the questionnaire-based outcome. So we can see around here a lot of symptoms that are reported by the patients. These are the number of patients having the complaints. The inner dotted line is a sentinel node biopsy, and outer solid line is a neck dissection. And this is the survey performed at 2, 4, 6, and 12 months. In first two graphs, we see a significant difference in terms of the symptoms in sentinel node biopsy and the neck dissection. But as we come to the 6 months, here we see that the difference is less, and at 12 months, we see actually completely overlapping curves. So there is associated morbidity, but over the period of time, it recovers. Again, looking at the arm abduction test, that is abducting the arm at 180 without pain or effort. Here again, we see a larger number of patients were able to do so at 2, 4, and 6 months compared to the sentinel node biopsy arm, and this was statistically significant. But again, at 12 months and 24 months, the rates were similar. This was in quick succession followed by the Japanese trial, which was published in JCO in 2021 in April. And again, this was a multicentric randomized control trial involving 16 Japanese centers. This established the sentinel node biopsy navigated neck dissection non-inferiority compared to the elective neck dissection in T1, T2, N0 oral squamous cell carcinoma. The primary endpoint of the trial was 3-year overall survival. This trial excluded the patient who had thinner tumors with depth of invasion equal to or less than 4 millimeter, stating the fact that the incidence of nodal metastasis is extremely low in this cohort. So in this, 97.1% of the patients underwent neck dissection compared to only 39.5% requirement of the neck dissection in the sentinel node arm. And during the follow-up arm, recurrence was observed in 18.2% and 21.6% of the patients in neck dissection and sentinel node biopsy group, respectively. Again, they compared the false negative rate of regional metastasis in neck dissection was 10.5% compared to 15.1% in the sentinel node arm, but the difference was not statistically significant. The median follow-up of this trial was 3.1 years, and they analyzed 271 patients. 33 patients were censored because of the lack of the event. And when they looked at the survival curves, the 3-year overall survival was 87.9% in the sentinel node biopsy arm compared to 86.6% in the neck dissection arm. Since non-inferiority margin was set as 12% and the 3-year overall survival in the Sentinel Node group was not inferior to the neck dissection, so the hypothesis was confirmed. Again, looking at the disease-free survival, the 3-year disease-free survival was 78.7% in the Sentinel Node group compared to 81.3% in the neck dissection group, and this was again non-inferior. When they looked at the questionnaire-based functional outcome in terms of stiffness, constriction, pain, numbness, shoulder drop, reach above the shoulder, neck appearance, again, there was a significant difference that was observed at least up till 12 months, 6 months, and many symptoms subsided by the end of 12 months. In terms of arm abduction test, again, there was a significant difference that was apparent till the completion of 3 months, and at 6 months and 12 months, the rates were similar. In terms of adverse event, again, there were the similar adverse event in the two group. One post-operative death because of the myocardial infarction was observed in the neck dissection group, and one because of the pneumonia in the Sentinel Node group. Recently, we have a publication from Tata Memorial Hospital that had extracted the individual level participant data from both the published curve of the randomized control trial. And here again, we see completely overlapping curve with more than 500 patients, establishing the oncologic safety of this procedure. So to conclude, Sentinel Node is non-inferior to END in terms of oncologic outcome. Sentinel Node biopsy limits the morbidity, which evens out at the end of 1 year, and it shortens the hospital stay. So with this evidence today, we have a Sentinel Node biopsy as one of the suitable alternative in the management of neck in node negative early oral cancer. Thank you.
Thank you, Richa. I think, am I audible? Am I audible?
Yes, sir.
Okay, Richard, that was a wonderful presentation. I was associated with the Sentinel Node way back in 1999 when I attended the second Sentinel Node biopsy at Zurich, and before that there was one at, the first one was at Canisburn, initiated by David Sutar's group. Somehow when I came back and tried to do it at our center, we used the, we didn't have the colloidal sulfur at that point in time, and we didn't have the dynamic gamma camera. So our results were certainly inferior in the sense that we had too many false negative. We always followed all our, it was a pilot study, and we always followed all our Sentinel Node biopsy with the supraomoid neck dissection, and we sub-serial sectioned all the nodes into 3 parts, and we looked at it. So we thought at that point in time that it was a lot of work for very little gain. However, looking at the Japanese trial and the trial that was you have shared with everybody, we do agree that if you have the resources and if you have the time, I would like to ask this august audience, how many of us will have the time to do a Sentinel Node biopsy, because it takes extra about 4 to 6 hours besides the procedure to do this. And the cost is going to add up in non-teaching hospitals, non-aided hospitals, like where you are doing it, where you have to bill the patient for everything, including the time. So you have to first do the injection, then you have to do the dynamic mapping, then you have to, after 2 hours again, do a static mapping, then take the patient to the theater, and then you go ahead with the dissection. And you may have more than one lymph node, as is been the experience, 2 to 3. So there is a lot of learning curve in other ways. So I would like to ask this august audience, would you like, if you had the facilities and no added expenses, would your caseload permit you to routinely do it? There's no doubt the morbidity is less, as both the trials have shown us, that all the morbidity levels out at 12 months. So certainly it has got a functional value. And obviously, I just wanted to ask one thing, Richa. All these cases, they used no other forms of adjuvant therapy? Am I audible? I'm asking you a question.
Yes, sir. So, sir, in Japanese trial, the adjuvant radiotherapy was administered to less than 5% of the patient and about quarter of the patient in the French trial. So they have a different rate of the adjuvant therapy administration.
Yeah, why I am asking you is there may be different considerations for radiation therapy. One that is related to the neck and one that is related to the primary. For instance, if you have a depth, despite as surface dimensions of less than 4 centimeters, but if you have the depth that is going below and you realize it only after the surgery, and you have other sinister components like perineural spread or perivascular spread, that may be a indication for adjuvant radiation therapy. And there are radiation therapists in this panel. I'd like to ask the radiation oncologist whether in such a situation, suppose you have a high risk primary and the sentinel node biopsy negative, would you like to irradiate only the primary and leave the neck alone? I mean, these are all treading, these are areas, controversial areas. So I would like your input because I'm not a radiation oncologist. I would be scared to leave this case unattended to, especially in our country where the possibility of patients disappearing after the primary surgery, I mean, lost to follow. So I would like you to just kind of shed some light on that. Any radiation oncologist?
Yeah. I am Dr. Ashi Agarwal, radiation oncologist in Max Hospital, Vaishali.
Please.
Actually, yeah, your question is very pertinent, but it becomes very difficult for us to leave with the patient is having high risk features in primary disease. As you have said, patient is having PNI. So although sentinel lymph node is negative, maybe we will want to radiate. Actually, I have not treated such type of case. Sentinel lymph node biopsy is very new. We are not doing routinely. So maybe, but at this point of time, I want to do it. Dr. Pavan Gupta, you want to say something?
Yeah,
Yes.
I just want to say this thing. We have just started the Sentinel node at Max Hospital, and I have just done recently. We did 3 cases, and it's basically we are doing it as a learning process. And we even after doing the Sentinel node, we complete the neck dissection. Actually, the supraomoid neck dissection. So it's just a learning curve right now. So it's too early to comment, but we are still learning, and I'm sure Richa's presentation has made us think better, and maybe we will improve on our inputs. And I would, Dr. Shino has put a lot of questions. I would request the panel, which is August panel, which is coming up, and I'm sure Dr. Shino would be there also. So let us take up these questions in the panel, and while we continue, because these are all certain lot of things that we need to discuss, and the panel would be the best.
Sure.
Yeah. So thank you, Dr. Shinoy. Thank you, Rashi. And I think, Rishabh, if you can share the screen, let's go ahead.
Now over to you, Dr. Kush.
Thank you, Dr. Rashi, and thank you all the speakers and the chairperson for this excellent session. Now we are moving forward to the scientific session number 3, which has 3D printing. As a variety of novel technology, 3D printing has been coming up in the field of healthcare, especially in cancer. And in oral oncology, 3D printing can help us enhance dental rehabilitation and maxillofacial reconstruction. To talk more on that, I'd like to welcome the chairperson for the session, Dr. Srinivasan sir, who is MDS prosthodontist. He has done his MDS from Government Dental College, Mumbai. He has special interest in head and neck maxillofacial rehabilitation. He has been awarded postgraduate fellowship in Maxillofacial Prosthodontics from Holland and Sweden, 2006 and 2008. He has also been the recipient of international fellowship from UICC, and he is the current executive committee member of Indian Prosthodontic Society and section editor of various journals. He is also the chief executive of Enhanced Head and Neck Rehabilitation and managing trustee of Enhanced Social Initiative, which has been developed by him to develop prosthetics and affordable and accessible to the nation population. To talk more on the session, I would like to welcome our speaker, Dr. Vani Parmar Madam. She is Professor Surgical Oncology, Oncoplastic and Reconstructive Breast Cancer Surgeon in Tata Memorial Center, Navi Mumbai. She has been past convener of breast cancer DMG in TMC Mumbai, and she has multiple publications at national and international level. I welcome Dr. Srinivasan sir and Dr. Vani ma'am and further.
Thank you. Thank you for your kind introduction. And I think without further ado, I'd request Dr. Parmar to carry on with the proceedings. Over to you, ma'am.
Yeah, thank you very much. At the onset, thanks Prathamesh as well as Dr. DeCruz for having suggested my name for this odd topic. And I am the odd man out, or the odd woman out, I should say. A breast surgeon now speaking in a forum filled with head and neck surgeons. So I do feel outnumbered, but I do hope I bring forth something that's interesting. And this is because I have additional interest beyond breast surgery. So let me just start by sharing my screen. So is my screen visible?
Yes.
Yeah, and I do hope that the slides also move. I've had some issues previously, so let's just hope that this time it doesn't give us trouble. So I have a topic to talk about, which is completely away from clinical oncology. This is 3D printing, something that has interested me for the last 4 years, and have got into it by taking small baby steps, I would say, because we began in a very small way in ACTREC. And now we have reached a level that I think we can bring it into clinical practice. I have a disclosure, definitely. And the disclosure is I'm a breast oncosurgeon. I don't practice head and neck oncosurgery. I do oncoplastic breast surgery and breast reconstruction, which is where my whole interest in getting into 3D printing came in. And of course, I do have a keen interest in something beyond clinical oncology, where I have projects in 3D printing as well as in AI, artificial intelligence, which is ongoing. And I have no conflict of interest as far as 3D printing is concerned. Well, we do know what is 3D printing. It's additive manufacturing in oncology, where we know that it has helped not only in health industry, but probably in the whole of industry. It has helped in shortening procedures, making technically everything easy, and reproducing of devices, etc., is very easy. But where do we really have a role of 3D printing in oncology is in anatomical trainer models, personalization by using or devising customized implants and prostheses, medical devices by rapid prototyping and manufacturing, in therapeutics by surgical guides and templates, radiation delivery devices, and of course in various other areas where we have seen in the last 2 years, it has helped us even in the pandemic situation. What are the type of 3D printers? Let's first understand the basics of 3D printing. Other than, of course, the technology where it is an additive manufacturing, 3D printers are various, and they can vary from anything from a simple fuse deposition modeling printers, which are easily available off in the market, to very large scale, the powder sintering and powder bed fusion printers, which are really large. They occupy a lot of space and they're very expensive. But let's understand the basics of 3D printing first. So the printers that we know are, of course, the FDM, or the fuse deposition modeling. There is photopolymerization, where we're using stereolithography or direct light processing to create the objects. Polyjet printing, which is also based on the inkjet principle, powder bed fusion, and bioprinting. The various substrates that can be used in 3D printing most commonly is polylactic acid. Polylactic acid, ABS, and TPU. ABS is acryl nitrile butadiene styrene, and TPU, which is thermoplastic polyurethane. These three are commonly used to create prototypes. They're used to create models, and they have some of them, especially the ABS and TPU especially, has pliability as well. So one can actually create models which are even pliable. Of course, use of resins and ceramics is highest in head and neck, and I think all of you as head and neck surgeons do know the use of resins and ceramics. Polyacryl ether ketones, PEEK, polyether ether ketone, which is also PEEK, and high impact polystyrene sheets. These are all different materials which can be used, which have bone-like rigidity, and they are very good for recreating more stronger units and can be used even for replacement of small bits of bones. Steel, titanium, aluminum, and metal alloys. I think titanium has been in use for a very long time, as well as steel, and especially so in head and neck surgery. Of course, bioprinting cannot be forgotten, and bioprinting definitely has a role, but that is something which is more futuristic when it comes to the discussions that we're having today. What would be the probable use of these? Let's understand. The FDM or material extrusion uses ABS, PEEK, PLA, polylactic acid, and various others like the ceramics as well as TPU. These are used primarily for making prototypes, used for surgical models, phantoms, applicators, implant medical devices. When we talk about material jetting or polyjet printing, this is, as I've told you, this is similar to an inkjet printing where polymers are actually thrown onto the paper and they are created using the softwares to have a additive manufacturing that's created. And the material that gets used here is ABS as well as acrylic clear resins. Now these require specific printers. They are used for creating surgical guides again, dental applications, simulation models, pre-surgical models, and trainer models. The third, that is photopolymerization, is the stereolithography and direct light processing. Here, resins are being used and ceramics, again used for creating dentures, for creating surgical guides, crowns and bridges, and also used to create hard tissue repairs, especially the dental resins and ceramic resins. The powder bed fusion is primarily an expensive affair. It requires a certain material which is more of powder, which is brought together. Now, there are various methods by which it's brought together. There is selective laser melting, selective laser sintering, and electron beam melting. Of course, these create very strong units and they can be used for bone replacements. They can be used for medical device manufacturing, processes, and surgical instruments as well. Getting into each of these, as I've said, polyjet printing or polymer printing, they can also be used to create various layers and surgical models can be created. Now, of course, these droplets, when they are used, they're selectively jetted onto a built platform. And using the software, we create a complete model and you can actually recreate the whole of the head and neck model. And that can be used for planning and technically for training of surgeons. As far as the stereolithography is concerned, this is primarily used for dental prostheses and to create the dental molds. Direct light processing is a similar method. In the previous one, the stereolithography, what is used is an ultraviolet light. In direct light processing, the technique is similar, except that you're using a DLP projector as a source for curing the photoresins instead of the ultraviolet light. Powder bed fusion, I've already talked about it. Of course, there are various methods. Sintering primarily uses laser to get the powder together and create a very compressed layer by layer building up of the object. Laser melting or the SLM. Here, a laser is used to provide heat and melt the powder together and compress it together. And electron beam melting, where it is an electron gun, which does the same with the metal powders. Now, obviously, these are the strongest. They create these are the such as aluminum alloys, titanium, stainless steel, and these can be used to replace even bone. They give the maximum strength. Now, the basic material extrusion is what we use for creating prototypes, and this is where we use fused filament fabrication. Various filaments can be used. The commonest, of course, is a PLA, and we use them for prototype making. Bioprinting, obviously, is still very much in research. It's additive manufacturing, where what we're using instead of ink is actually cells. So these are cells and biomaterials, which are then laid down layer by layer to create an object or a tissue. This obviously is still a lot in research level. Whatever has been created so far is really in small nanograms, which are used basically for drug testing. As far as 3D printing in ACTREC is concerned, I'm very proud to say that we did start this in a very basic form, in a very simple, modest lab in June 2018. The reason behind starting this whole lab was to print silicon. And one would say that would be a crazy idea because there are no silicon printers available in the world. They'll be still in research stage. There are no printers available for outright purchase. So what we did was we tried to fabricate together a printer which could print silicone. And the reason was, obviously, I'm a breast surgeon, and what was the reason why we built that up was to print breast implants. And that's where the whole interest started. We began the lab with a fabricated FDM 3D printer with a very small footprint of 19 by 19 centimeters. You can well imagine that's smaller than a scale. So it's really a small printer. That's the printer that we had. And this is compatible with PLA, ABS, and TPU. We started off with the project of trying to print silicone, a tedious procedure, but we got funding from BIRAC, which helped us to build this up. The current status is that we are able to print small amounts of silicone, small sizes. So we are ready now to actually print processes like ear, nose, and of course, small breast implants. So obviously, these are very small ones. They're still in research, and there's a lot of work still to be done. What it did help us was to get an offshoot. We created breast onco-trainers, and we used this in an international conference in Goa in 2018 October to have oncoplasty being trained on these models. Now, this was a mix of both 3D printing of the mold and getting the silicone cast into it as a mold cast. Obviously, we have moved way ahead from there now. We are able to print the silicone. We should be able to print all of these onco-trainers as 3D printed models. COVID brought in a change. We used the same 3D printing lab to create face shields. Of course, this was just to let you know as to what all we have been able to evolve with the small 3D printing lab that we had in-house. We created nose clips. We even modified them to be used with eye loops, created microvascular small clips for the anatomy skill lab for cadaver workshops. And we used the same 3D printer to develop certain radiation delivery devices, assisted devices. So this is for the shoulder. We've had vaginal applicators, rectal applicators, and of course, even for head and neck, we had the head and neck support device that was created. And this is obviously a 3D printed mold where we used foam to create the actual headrest. Prostate brachytherapy applicators, cervical brachytherapy devices, Fletcher suit. We also created from the PACS and from the HIS, we got the images of CT and MRI, created skull models as well as the brain models, and these are for robotic training. But what is probably most interesting for all head and neck surgeons will be that we did end up in building our own image to print file for mandible. So we are now ready with the prototypes for mandibular resections. We can have an absolute planned cutting guide for the mandible as well as for the fibula, including the fibula table, where the tray that we can use for putting together the fibula pieces. Obviously, this will shorten the procedure, which will make the whole procedure very simple, and we can have the reconstructed fibular graft for the post-mandibulectomy, allowing us to do much limited resections and even probably saving the ramus where we can. So including the dental guide for placing the dental implants at the same time that the reconstruction is being done. Now, obviously, this requires a lot of coordination with the head neck surgeons, the plastic surgeons, and as well as the 3D printing lab. And we are ready now to get this into clinical practice. In addition to this, we've also created the phantoms for dosimetry. This is a breast phantom, which was created through images of the patient and made into the STL files. We then printed using thermoplastic polyurethanes or TPU. Using water as the interface, we created the dosimetry phantom. This has been now used to complete a thesis and dosimetry study of a student in radiation oncology. Obviously, this is now ready to be applied for various other parts of the body. We can create phantoms for head and neck. We can create phantoms for various other parts of the body. The zygomatic implants model has been designed again from images that is taken from the CT scans, printed making STL files. And now these are the images that were created for a zygomatic implant. Medical devices can be made. Laryngoscopes have been printed. They've been tested out in our OTs. One case study that I would definitely like to share, there is the work that has been done with Dr. Sandeep Gurav in the dental and prosthetic surgery. This was the prosthetic management of a nasal defect in xeroderma pigmentosa. This 8-year-old child was born to a third-degree consanguineous married couple, had a growth on the nose since 3 months with pigmented skin, speech and language milestones were delayed. She had photophobia and also had pigmented conjunctiva on either side of the limbus. The growth on the nose was obviously a squamous cell carcinoma, moderately differentiated squamous carcinoma, which was resected. And our job was not till here, but essentially to help in creating a nasal prosthesis. The child would not allow for the nasal mold to be taken. So we had used the images to create the nasal mold. The negative mold of the patient-specific nose was designed and 3D printed. Obviously, it required, we used PLA to create these molds. It did require a slight bit of modification based on the child because the child was also growing. There were slight changes that was created. And based on these, the nasal prosthesis was then printed. So we did use a combination of mold casting as well as, so 3D printed mold and a mold casting with silicone. This is the clay impression that was done and final prosthesis. So you can see that the child eventually is now a happier child. The tumor has been resected and a nasal implant has been now made with silicone, mold casting of silicone with a 3D printed model. Keeping all of these in mind, we have now moved on to the next level. We have created our own next level indigenous 3D printer, which is a much larger footprint. This is a 60 by 45 by 35 centimeter printer that has been completely built in-house in Actrec. The beauty of this is this has a large build volume. It is a customizable and modular platform. We can modify it as per our need. It has an additional multiple material extrusion possibility. We can have 4 materials simultaneously being extruded under different controls. So 4 different colors, we can actually create a single model with all the 4 materials being used. It is compatible to various materials, PLA, ABS, PETG, TPU, and HIPS. It has Duet 3D electronics and completely Wi-Fi controlled. So we don't need to have it connected through a wire to a software. It's completely Wi-Fi controlled and we can have even a distant control on the printing. This has been made in-house and I'm very proud to say that we would be using these now to create larger numbers, larger prototypes, as well as modeling, and we will be using this in clinical practice. We still have a long way to go, but we would be using these now in close collaboration with the Hedonic surgeons as well as the plastic surgeons to have the mandibular models to be created, as well as helping in the resections and reconstructions. Thank you very much for the opportunity to share our very small, short, brief experience that we've had, and we plan to be back again with much more to share in the due course. Thank you very much.
Thank you, Dr. Parmar. That was, I think you just blew everyone away with the phenomenal work that's being done at Actrec today. So I think without the slightest doubt, I think the writing on the wall is very, very clear. The future of Hedonic reconstruction definitely lies in digital technology and 3D printing. So just like to add on that, yes, definitely it makes surgery planning so very easy. Moving away from conventional eyeballing, it removes the guesswork in the operation theater, and I think it would make life, virtual surgical planning definitely would make life so very easy for reconstructive surgeons and also for prosthodontists like me who would like to probably fast track, are constantly looking at fast tracking the process of rehabilitation. Today, 3D printing is going even beyond, it has a huge role to play in remote healthcare delivery. So we are involved in a project where we are looking at fabricating facial prosthesis even without seeing the patient. So we are looking at, in fact, I'm personally involved in this project where we are using the mobile phone as a scanning device already. And so that data from home and treatment in your neighborhood being our vision. So patients don't have to travel anywhere at all in future. And we've created these prototypes wherein you can have prosthesis absolutely without seeing the patient. So the patients don't have to travel. And I think that's where the future of technology is. artificial intelligence and machine learning are going to change the way head and neck reconstruction is being practiced across the world. And I think I have always believed, and I think you've proven it as well now, that technology is not always expensive. It's a myth that technology is expensive and cannot be adopted. In fact, technology very often reduces the indirect costs of treatment that we don't really, we very often don't account for. So I think that's definitely the way forward. And I thank you for sharing a very, very futuristic presentation. In fact, the future is in the present already. So
yes, I completely agree there. So 3D printing has actually taken us leaps and bounds into the next level. And I guess having it in-house is even more an advantage. And that's very, very important for all institutes to probably look forward. Yeah, thank you very much.
Absolutely. Thank you.
Thank you, ma'am. Thank you, sir, for this excellent session. You and your entire team for this work you have been doing at 3D printing lab at TREC.
Thank you. Thank you very much.
Yes, ma'am. Thank you. The next, moving forward, the next session is on maxillofacial prosthodontic rehabilitation of oral cancer patients. To chair this session, we have Dr. Samit Chopra, sir, who is chief in the Department of Head and Neck Surgery at Patel Hospital, Jalandhar. He is also the executive committee members of FHNO and Association of Oral and Maxillofacial Surgeons of India. He's been state secretary for Mission Pink Health Punjab, and he's also been the chairman of Oncology Committee of Punjab. I welcome you, sir. I also like to welcome the speaker for the session, Dr. Jyotsna Seth, who is professor in the Department of Prosthodontics and Oral Implantology in Seema Dental College and Hospital. She has done her graduation from Saraswati Dental College and Hospital in Lucknow. She has been trained in palliative care in IAPC course, and she has also been awarded Tobacco Cessation Program Fellowship by ICanCaRe. She has delivered multiple lectures and she has many publications to her name, and she has also been awarded as Best Prosthodontist in the year of 2021. I welcome both of you, and please start the session.
Good evening, all. And again, it's a pleasure to be associated with this initiative after a fortnight. Without further ado, I think we'll have closing comments and discussion at the end of Jyotsna's talk. Kindly go ahead if Dr. Seth is here.
Yes, sir. Thank you, sir. Am I audible? Push.
Yes, yes, you are, Jyotsna. We're looking forward to it. Yes.
So is my screen visible?
Yes, please go ahead.
Right, sir. A very good evening to all of you, and to respected chairperson. And I really thank ICanCaRe Second International Oral Cancer E-Conclave to make me a part of it. And thanks Reena ma'am and Pawan sir, and to have me on this note. Is this moving? Okay.
Put it on the full slide, please.
Right, sir. I will surely do that.
You don't have to remove that. Just share the screen and just go down and just put the full slide. Share the screen.
Is it visible? No, not yet.
No, it has got disconnected. Just share the screen.
Right, sir.
Or you can just share that particular tab. Yes.
Right, sir.
Yes. Yeah.
I thank ICanCaRe Second International Oral Cancer E-Conclave. Greetings from Seema Dental College and Hospital, Rishikesh. To begin with my presentation, gratitude to my guru and my inspiration, due to whom I'm here right now. The topic given to me, maxillofacial prosthodontic rehabilitation of oral cancer patient. I would suggest that Srinivasan sir must be understanding my condition right now, because within 10 to 15 minutes, it's very difficult to present that maxillofacial prosthodontic rehabilitation. Still, I will try my level best. Coming to stats of oral cancer in India, a little bit about stats, what we know. The Southeast Asia, they are the most common cancer in males is oral cavity, lungs, esophagus, and stomach. In females, the most common site is uterine, cervix, breast, and oral cavity. And in the most prevalent form of head and neck cancer in India is oral cancer. And the main two forms, that is the tobacco smoking and use of smokeless tobacco, they are identified as the main risk factor. Now, when we talk about the maxillofacial prosthodontics and its rehabilitation, it's a quite alarming situation that people really actually doesn't know about, that there is some maxillofacial processes still prevailing, because there was one study which was being done and they said that 53.9% of the population only know about the implants and lesser than that know about the maxillofacial processes. It could be due to the low awareness, we can say, the low literacy level or the low socioeconomic status. The other study, it is not only the population, even the medical practitioner were not knowing that which case has to be transferred to the maxillofacial prosthodontics or not. 34.2 people were not knowing as that the prosthodontists are doing such work. And the 10.9% only of the population of the medical practitioner were able to answer the questions of the maxillofacial prosthodontics. So it's a little alarming situation. And I think the need of the hour is right now is the awareness regarding maxillofacial prosthodontics. Coming to the facial appearance, now starting with the maxillofacial prosthodontic, facial appearance affects a person's ability to communicate, and it actually increases the self-esteem and character. And the facial, when we talk about the facial appearance, we believe in facial symmetry. You can see here, nobody likes all these photographs. Why? Because we love facial symmetry, and facial symmetry is all about the facial proportions. Facial proportion is like hairline, the horizontal lines and the vertical lines, all about this. And when there is not a more severely handicapped person than a patient with a gross facial disfigurement, since the most exposed portion of his body is unkindly distorted. And here the picture comes of a maxillofacial prosthodontics. Now, what is actually maxillofacial prosthodontics? Is defined as the branch of the prosthodontics concerned with restoration, replacement, or both of stomatogenetic and associated facial structures by artificial substitutes. It encompasses the prosthetic rehabilitation of patients with the oral, paraoral, or facial defects. And now the replacement of that processes is we call the maxillofacial processes, which is restoring the normal anatomy, the appearance, protects the tissue of a defect, and provides great psychological benefit to the patient. Now, why prosthetic rehabilitation? Why not surgery? We have a great session. I was listening to Dr. Mudit sir. They were really excellent sessions regarding plastic reconstruction. But at some times, at few cases, we have to go for the prosthetic restorations. What are those cases? When the recurrence of the tumor is likely, advanced age of the patient, poor health, when the defect tissues are heavily irradiated and the blood supply is very less, and with the large defects. Now, it is not like that the maxillofacial prosthodontics have come into picture right now. No, it was from initially 1950s. You can see the Ambrose Perry and the gunner with the silver mask, a French soldier, and a Kingsley. They also have an artificial appliances. Now, what are the objectives of the maxillofacial processes? Restoration of aesthetic, restoration of function, protection of tissue, therapeutic or healing effect, and the psychological therapy. Now, while talking about the management of MFP, we will say that the personal history of the patient, the dental and the medical intra and external examination of the patient, the psychological and the patient risk assessment, and a surgeon should consult with a dentist or a prosthodontist before to do any surgery. Now, I would not say that it is just an isolated branch. We will say that it's a combination of multidisciplinary approach when we have an oncosurgeon, anesthetist, plastic surgeon, ENT surgeon, oromaxillofacial, radiotherapist, diet counselor, psychotherapist, palliative care also, along with the prosthodontist. And when a little bit about the maxillofacial defects, when we talk about, basically it is being divided into three, that is the congenital, acquired, and development. When we talk about the congenital, we know that it is during the birth. And when the acquired, we talk about it is due to trauma or excision or surgical excision of any tumor or something like that. Or a classification, when we talk about the development, it is due to because of some of the genetic predisposition, like there is a prognathism or retrognathism of the mandible. And when we talk about now classification of maxillofacial prosthesis is further divided into three majorly: the extraoral, intraoral, and the combination of it. Extraoral, when we are talking about the cranial or the facial replacement; intraoral, which is only involving the oral cavity; and the combination, which is involving the intraoral as well as extraoral. Now, when we talk about the intraoral processes, which is further being divided into maxillary, mandibular, tongue processes, and the lip processes. When we talk about maxillary processes, there are a lot other, and when I will explain you later, and extraoral processes, which we are not going to deal today, because we are talking about the oral cavity. Combination, we will talk little 2 or 3 slides, because we are dealing with the oral cancer, which is the more, when the more thing is being involved. When we talk about the intraoral processes, we majorly talk about the obturator. And then feeding aid processes, about speech aid processes, maxillary ramp, maxillary saliva stimulating processes. In the mandible, we talk about the preservation of the alveolar ridge, mandibular colectomy processes, mandibular guide flange, and the tongue, the lower augmentation or the upper augmentation. Now, when we talk about the maxillary defects, I told you this is the congenital or acquired. And acquired, we have a traumatic, pathological, post-surgical excision of the tumor. Now, the maxillectomy defects, as the classification is being given by Armani in 1978, and they said it is being divided into 6 classification. The first, which is not, it's a unilateral, but not crossing the midline. The second is posterior to the canine. Third is when it is middle of the palate, hard palate. And the fourth, it's a bilateral and crossing the midline. And in class 5, we would say that this is only the posterior side is being involved. And in class 6, would say the anterior segment. In the maxillofacial defects, the only problem we have, the majorly problem, is the sucking difficulty, nasal regurgitation, dental anomalies, airway problem, aesthetic, speech, and psychological trauma. Now, before surgical treatment planning, we have these team members, including the prosthodontics. Now, surgical enhancement of the defect is also necessary. We want to have a preservation of the hard palate and preservation of the ipsilateral premaxilla. There are a few surgical enhancement, because for any prosthesis, we need retention. And for retention, we need certain anatomical landmarks to get the retention of that prosthesis. So we would like to have the teeth on the surgical side, because the functional fulcrum line then shifts to a more favorable position. When we talk about suggestions to a surgeon, I would like to say that we should have many of the alveolar process and the teeth as possible should preserve without compromising complete removal of the tumor. When we talk about processes, we should not cut with along the edges of the bony surface. There should be at least few teeth available to the defected side, so that the fulcrum line to be shifted to the favorable position. And when we talk about the transalveolar interproximal cut, we would suggest that it should not cut between the root, but it should cut between the socket which is being extracted. Now, these are the various indications of the processes, and we have them majorly for the maxillary defect. We use obturator. Obtura is basically closing and opening. So that is what the term comes from, obturator. So it's used to close a congenital or acquired tissue, primarily or hard or soft. Now coming to what are the advantages. This is comfortable, reduce cosmetic deformities, sports upper lip and cheek, restore adequate speech, deglutition, and mastication. Now we have 3 types on the base of treatment, phase of treatment: immediate, transitional, and the permanent. And material use, this is the metal, resin, or silicone. The area of restoration could be a palatal or the meatal. Now, when we talk about the immediate, it is just after the surgery from 7 days to 6 weeks. And we can get the retention on the screw, sutures, denture, dental ligature wise, and RPD clasp. When we talk about the interim obturator, usually constructed after 7 to 10 days. And when we talk about the definitive obturator, we need to have timing depends upon the size of defect, the progress of healing, and the prognosis of the tumor control. A few cases just to make you a little more clear that how these things are being done. So this is the intraoral picture of a patient, which is showing this Armani classification 1 defect. This is the impression which is being taken by the alginate, and the beading boxing of the impression is being taken, and the working cast is being made. And for the retentive wires are being made, and the wax up is being done. And this is the flasking to be done. And this is record based in situ, fabrication of the occlusal rim. While for fabrication of the occlusal rim, we can do the trine in the patient mouth. And then this is the obturator inside the patient mouth. This is the post-operative. These are the pre-operative and the post-operative pictures. Case 2, just a little for the patient complaint of difficulty again in chewing food, swallowing, and difficulty in speech, got a tumor involving right maxillary quadrant. You can see the patient has reduced mouth opening due to the trismus, which we were talking about. Even Dr. Mudit sir has told about this. We can also see that the facial symmetry, there's a gross asymmetry was seen on the right side. Again, this is the primary impression, the cast, and this is the final impression. This is the master cast by the border molding, which we have done. Again, the teeth setting and the trine in the patient mouth. This is the final process. This is the bracing arm, which is holding actually, and this is the cameo. This is the outer and the inner surface of the denture. And this is the final processes inside the patient mouth. Now, this is another case, which is showing again the secondary impression of the. There are a few more cases when we are resin bonded attachments. The only problem with the maxillofacial processes is the retention. So whether we should have more teeth which are present in the mouth, we can have a more retention. That is what our main objective is. We can also use a cast partial framework with this so that their retention will be and stability will be improved. This is another, the speech aid processes. There is another huge topic when we are talking about the palatal lift processes, which can be used in the velopharyngeal incompetency. When we talk about the mandibular, this was all about the maxillary reconstruction. When we talk about the mandibular reconstruction, we know that the defects result from surgical excision of the benign mandibular tumors or oromandibular malignancy. This could be due to trauma or osteoradionecrosis. Now, this was the classification given by, and thanks to this, I would give this credit to Pawan sir, because I've forgotten this classification. This was Hcl classification. The H is involving the condyle, L is the lateral segment of the mandible, and C when the anterior segment is being involved. And there are the 8 other combinations which are being used in this classification. Now, the major in the mandible is the mandibular guiding processes, which is actually guiding and realigning the teeth to the occlusion. And the second, the deviation of the mouth is being reduced. This is, you can see the deviation, there is a facial asymmetry, and this mandibular guiding flange helps in aligning the teeth to the occlusion, the normal occlusion, and reduces the deviation of the mandible. There are various mandibular reconstruction with the bony grafts and the implants which are being used. And there is also mandibular lip defects, which is the custom cast retentive elements with the resin bond retainers are being used. Now, a little bit about the extraoral processes, as today is not our topic of the extraoral, but how it is being related to the oral rehabilitation. I would just explain you. There are various types of extraoral processes. We know that upper facial, middle facial, and hemifacial, the nasal, orbital, and the auricular, right? So we know even the causes, the neoplasm, the burns, the congenital deformities, and the trauma, right? Even now these days, the mucormycosis. That we achieve from these processes, we know that aesthetics, the function, the protection, the healing, and the psychological. Now, the major role is the combination processes, where the intraoral as well as extraoral processes both are being combined. You can see here, this is the mid-facial processes. You can see in the picture where the large mid-facial defect is being present. In this, oral processes for the partially dentate patient with a large mid-facial defect. Here, there is an edentulous patient with a large mid-facial defect. So we are giving the intraoral as well as the extraoral processes in the combination syndrome, in the combination maxillofacial processes. This is the orbital exenteration, maxillectomy, and cheek resection defect. This is the nasal processes retained by an RPD obturator processes with the magnates, which is another method of retention. We have a lot of other retentive methods like anatomical, surgical, mechanical. We are using all these to have a better retention, stability, and support of the processes inside the patient mouth. And when you actually realize you didn't mute your Zoom meeting. And now coming to the recent advancement, there are a lot of recent advancement. When Dr. Vani ma'am told about the 3D bioprinting, yes, we are doing CAD remodeling also. The processes designing are also being, there is a virtual try-in also, and rapid prototyping is helping us a lot in the maxillofacial processes. Now we can see that there are also the maxillofacial implants which are being used. There are auricular, there are nasal, there are orbital, mandibular processes, but the obturator. But today we are specifying on the obturator. We will say there are a lot of advantages. Again, I told you they will improve retention, elimination of the use of adhesive, accurate processes, improved skin hygiene, increased lifespan of the processes, and it also enhanced aesthetics. Now, implant retained obturator, the large defect which is being seen, and the osseointegrated implants are being used. New trends are implants are in use, zygomatic and the craniofacial. And we had talked about the zygomatic implants which are being used now these days for the maxillofacial rehabilitation. I think being a prosthodontist, which I should say that we are not only just replacing the oral cancer, we have also be in a cinematic world. With these words, we can see a lot of Bollywood actors using this. And I will be ending my presentation. So to summarize, I would say that we restore, repair, and make whole those parts of the body which nature has given, but which fortune has taken away, not so much that they may delight the eye, but that they may buoy up the spirit and help the mind of the affected. This is just a photograph of the palliative care. We at Seema Dental College, we are also the palliative consultants. We go to a hospice where we give our kind of a services to those people. And I think this is the part of us that we should work as a team. And I would say that learning and improvement is lifelong process. Keep learning, keep moving. Thank you.
Great talk, Dr. Jyotsna, and I think I speak on behalf of everyone who attended it that you changed a lot of perspectives with regard to maxillofacial prosthetics. In this age in which most of us as head and neck or reconstructive surgeons end up reconstructing a defect as opposed to rehabilitating it, the issue that arises is that we don't have robust data which actually helps us select the ideal patients for obturation or maxillofacial prosthetic rehabilitation as opposed to flaps. The general rule of thumb, unfortunately, is that patients who are not considered medical or surgical candidates for free flap reconstruction are typically sent to the maxillofacial prosthodontist. I'm glad that you made a very strong point about that not being the case. Of course, extraoral prosthesis, which is outside the topic of this presentation, there is a definite role and a big advantage of prosthetic rehabilitation. Intraoral, I think that we are not only in the phase of combination prosthetics, but I would call it a combination rehabilitation, where reconstructive surgeons like ourselves will do the surgery and then send the patient to you for further optimization. Just 2 days back in our clinic, we were talking about a patient who did a fibula free flap. He had VSP and everything, but despite that, we felt his occlusion is a little off. So our maxillofacial team then sent him for a mandibular guiding flange prosthesis, just like you mentioned in your couple of case vignettes. Just one point and one question I have before any of the other faculty or seniors have any point to make. Maxillectomy defect classifications, you pointed out an Armani classification, which was earlier. From a head and neck surgical standpoint, there are a couple of classifications that are used more often these days. The James Brown classification and the Okai and Erkin classification. They are the ones that generally use more. But again, you're absolutely right in mentioning that if you're using one classification, just stick to that. Right, one question I have is that frequently when we do a maxillectomy, the trend, of course, is to preserve as much native dentition as possible, especially the central incisor, even on the ipsilateral side. But sometimes tumor considerations will force us to take the central incisor on the opposite side as well. In that case, your surgical suggestion to us would be what? Should we complete the pre-maxillary excision and give you the canine on which to anchor your prosthesis? Or should we leave the lateral incisor on the other side and potentially make it a vascular watershed? It may or may not survive or be vital at the end.
It's a very pertinent question. So because what happened in, we actually want there should be no rotation of the prosthesis. So that is why we're taking central incisor and the second or third polar to the other side, which is being present to the defective side. So we are taking the central incisor to the normal side and the molar from the defected side. So we want these two so that there is we call it a trigonal kind of a quadrilateral kind of a anchorage, which we need in the prosthesis. So there is less rotation anterior posteriorly, which will help in retention of the prosthesis.
Okay. The question, again, thanks for this. The question pertained to whether we should complete a pre-maxillectomy on the opposite side in case we have to remove the opposite central incisor, or whether we should just leave the lateral incisor intact and not complete a pre-maxillectomy for obturator. Just I think breaking it down simply for us head and neck surgeons, just educate us as to what teeth or what classes of teeth are you happiest with in terms of obturator retention. That's my question.
The lateral incisor, sir.
Okay, that's fine. Thank you. Any questions, any comments? I see Dr. Pavan is here. A lot of senior guys, Dr. Prathamesh is here. Any questions or comments?
Just I will ask Dr. Jacob. He wants to say something. Dr. Jacob, please unmute yourself.
Yeah. Thank you so much. I didn't. I didn't expect to be asked to comment here, but thank you so much for that. Unfortunately, I was not there for the full lecture, but yes, more and more we are doing now free flaps, and my sincere request to all the reconstructive surgeons is please do bone containing free flaps. If you do a lot of soft tissue flaps, it becomes extremely difficult and sometimes almost impossible to rehabilitate these patients. And, just like my young learned colleague said, to your question, if it's a lateral that you would like to retain, please don't retain the lateral, please extract the lateral. What we would like you to actually do is to extract the lateral and make your cut margin through the socket of the lateral so that we get good bone around the canine. The tooth that is adjacent to the defect is of prime importance to us, and either a central or a canine can be kept. If a lateral is going to be kept, then we need to root canal and cut it at the gum line. So, I don't want to take too much time. So thank you very much for acknowledging me here. Thank you.
Point very well taken, Dr. Jacobs, sir. We had the same thought philosophy, wanted to drive that point home. You'll be glad to know that most of us in the reconstructive field are beginning to do more and more bone containing free flaps. Of course, mandibular defects were always the purview. Absolutely. But for maxilla, for single segment or single buttress reconstruction, we have multiple options. The radial osteocutaneous, which unfortunately the implantability index is not very high. Right. But in our country, we are trying or striving hard to make sure that we implant those patients. But that's a good single buttress or a pre-maxillary reconstruction that we use. Absolutely. For lateral single buttress, we end up using a fair bit of tip of scapula flaps. Okay. And of course, for a full maxillectomy, our choice would be a fibular osteocutaneous free flap for multi-buttress reconstruction. So, but you'll be glad to know that most centers across the country are beginning to follow that philosophy so that we can rehabilitate these patients. Of course, with your help and expertise. Thank you.
Absolutely. So I understand in the maxilla that getting the vein and the artery is difficult. So wherever possible, we can either rehabilitate them with a bone containing free flap or just do a good skin line defect for us. And as long as we have good teeth, we have some good teeth, we can give a fantastic obturator to the patient.
Great. And there are other vessels that are available though, sir. Dropping it out into the neck is something. But for non-squamous histology with unpredictable nodal patterns of drainage, we're able to hook it up to the superficial temporal artery and vein. So that pedicle is shorter. Of course, we can use vein grafts for the artery as well as the vein. I believe Dr. Srinivasan has a point to make. We can probably take that and then close this topic.
I would suggest that we start that panel. And Dr. Srinivas is also in the panel. So I would suggest that if we can, because we are running short of time. So thank you so much. And really,
Thank you. Yeah, great discussion. Thank you. Thank you.
Thank you, sir. Thank you, sir.
Thank you.
Thanks.
Thank you so much. We had an excellent scientific session from very senior faculty members. And thank you so much for sparing your time and making this sessions very fruitful and for our audience. Before moving on to the panel discussion, I just want to like to share one of the introductions that we have made at ICanCaRe. We have launched the Certified Tobacco Cessation Specialist course along with Gujarat University. It is accredited by Gujarat University. And it is believed from very senior members, senior doctor faculty members, that the head and neck surgeon community should be aware about the tobacco cessation processes. And it's like another treatment process and for tobacco cessation. And they should be learned about these practices, the advancements that has been taken in this particular domain, and so that they can achieve a very successful cessation with their patients. So with ICanCaRe, we have come up with this structured course along with accreditation from Gujarat University, with the help of the experience from Dr. Pavan Gupta and many other senior faculty members, the doctor members, and so that the knowledge can be dissipated and the skill up can be done for our doctors, so that more and more people are able to help. They can be helped to quit tobacco very successfully. As a matter of fact, we have last year we have trained and certified about more than 608 doctors across the country, and we look towards getting more and more people gaining this knowledge about tobacco cessation, the advancements in tobacco cessation, so that they are also able to set up their own tobacco cessation clinics in public as well as hospitals. As along with that, we also come up with a software called ICanCaRe Tobacco Wellness app that will be able to assist them during their entire succession process with their patients. Thank you so much, and we all look forward to the panel discussions that we are going to have. So I now invite Dr. Kush Saad to kindly take and introduce for us for the panel discussion. Thank you so much.
Thank you, Rishabh. As we are running late, we'll start with the panel discussion for today. The topic for the panel today is local surgical procedures for oral cancer patients. And I'd like to welcome the moderator for the panel, Dr. Arun Patatheli sir. He is Senior Consultant Head and Neck Surgery at Tata Medical Center and Hospital, Kolkata. He is also the Secretary of FHNO. He has special interest in head and neck surgical oncology, tissue banking, and stem cell research. He has more than 40 publications to his credit, and he also has ongoing research for human oral cancer stem cells and cancer-associated fibroblasts from patients' tumors and the establishments of his primary culture, and to determine the genomic signature of oral cancer patients who has failed the treatment in gingival regions. I welcome Dr. Arun sir, and please take over the panel further. Thank you, sir.
Thank you, Kush. Are you all able to hear me?
Yes, sir. Yes, sir.
Yeah, thank you. So
If
I
you
think,
can keep your mic a little better, sir. So
yeah, I'll speak louder. Is it better?
Yeah, this is better. This is better.
So I'll quickly go into the to my duty of the day, which is to present a panel before you. And we are running a little short of time. I think exactly an hour behind schedule. So I would probably want very crisp, clear answers from the panel so that we can pass across some key messages. And of course, welcome, Dr. Handa. You are there to moderate, and you feel free to join in at any time. We'd be very happy to sort of hear your experiences. And Dr. Goyal is the other member of the chair, if he's there. I can't see him. Is he there, Kush?
He's not there, sir. He's not.
Okay, so we are joined by a great panel here. So a lot of learning is going to go on this 55 minutes that have been allotted to me. Very senior members like Dr. Shenoy and Dr. Mohanty, who I would say have been my teachers as well. And a lot of young Turks who do some great work all over the country. Srinivas, and we have people spread across specialities. Like we have a radiologist, a maxillofacial surgeon. We have people from the plastic, hardcore head neck onco surgeons like Dr. Dushyant and Dr. Shenoy. And of all the damage that we do, I think people like Srinivas who come to our rescue time and again with his prosthetic skills. So I'll just share my screen and continue. Good enough? Can you see my screen now, Rishabh?
Yes, yes. Please continue, sir.
Right. So thank you for having me here. ICanCaRe has been doing a great job over at least past few years in bringing various issues which hitherto are not discussed in routine fora like prevention and rehabilitation. And it's great to be here. So we are now moving in some from technology, which is right at the forefront, to something we have been doing for years, is doing local procedures for oral cancer in the mouth. But believe me, with the great panel that we have, we are going to get new perspective on things which we have been doing for times in the past. So just let me introduce the panel to you. We have exactly 55 minutes to go through that. And please do alert me when I overshoot time. I think we'll stop at 55 minutes. So we have Dr. Srinivasan, who's a prosthodontist, Dr. Arjun Singh, who's a maxillofacial surgeon, Dr. Shetty, a radiologist, Dr. Mahanti, and Dr. Aparna, who are radiation oncologists.
Arun, just a correction. Ratan is a head neck surgeon. So
okay, so from the list I got, I'm very sorry, Prathamesh. So we have one more the onco surgeon in the list today. And my slides have been prepared with the previous list of panelists, so it was a little path heavy. So forgive me, but I'm sure we have interacted so much with pathologists that our surgeons would be able to answer a couple of questions that I would pose across to you. So I'm sorry, this case one. So we'll start with the first case. She's a 42-year-old housewife. And if you notice in the lower alveolus, there are a few teeth missing. So when this lesion started, it was believed that it was due to a dental trauma. And the first thing that a dental surgeon did was to take off her teeth. But she's, so the tooth was sacrificed on that front. But the lesion continued to grow. I would also like to point out that if you look at it, they are multifocal. There are many small little excrescences that you see on the mucosa. It was painless, no comorbid conditions, and her initial biopsy revealed severe dysplasia, no invasive cancer. Please repeat malignancy if suspected. So that is a description. She did not have any nodes in her neck. So we don't have a pathologist, but I just go to the surgeons first, to whom these patients usually report to. So either Dr. Dushyant, now that we have a biopsy in a multifocal lesion which says there is no cancer, are you ready to believe it, or do you want to go ahead and do something more? And if you're doing something more, what would you like to do?
Arun, I think I will like to know from where the biopsy was taken. It was a superficial biopsy from the keratotic area, or was it an actual biopsy from the junction of normal tissue and the tumor? Because it is really a very suspicious tumor, and there is a very high index of suspicion of invasive squamous cell carcinoma. So I will either review my biopsy or like to redo a incisional biopsy or a punch biopsy in that case.
So, Dr. Dushyant, in a multifocal lesion like this, which one would you choose and how would you choose?
Most suspicious one I will do. I will take a biopsy of that. Whichever is most clinically suspicious. I may take multiple biopsies also if it is required.
Dr. Ratan, anything more that you want to? I've just put up a few things down there, a few aids for biopsy. Do you use any?
Sorry, there is no.
Dr. Ratan Shetty, we are not able to hear you. There's a lot of background noise.
Yeah, sorry, I'm at.
We'll give Dr. Ratan another opportunity. Dr. Ratan, we are not able to hear you. There is some disturbance in your audio.
Yeah, sorry.
Oh, there you go.
Okay.
Now we
can. Yeah, I would. I tend to agree with Dr. Dushyant. I would do an incision biopsy from the most representative site. Regarding brush biopsy has been tried. You can take a brush biopsy and see cytology of the cells from the brush biopsy will tell us whether there is any.
This is a tongue lesion, Dr. Ratan. This is a tongue lesion, and there has been a biopsy.
I would always advise an incisional biopsy, because incisional biopsy is the gold standard for tongue lesions, which helps me in deciding what further course of action needs to be taken.
Right. So I'll go on to someone senior. Dr. Shenoy, isn't it very sort of irritating sometimes that you have taken this biopsy, you have sent it to a pathologist, and here the patient stands with a negative report in his hand, and you are also frazzled. Now, what do you do? Why do these come negative in the first place? And what do you do about this? How do you deal with this situation? Dr. Shenoy. Dr. Ashok Shenoy? Okay, maybe Dr. Arjun Singh.
Yes, sir. So I think, sir, there can be many reasons for the biopsy to come negative, and in us, in this particular case that you put up, I think it looks pretty suspicious, but maybe the biopsy was taken from a less representative area. In other sites, I think because of the extensive keratosis, also because of the chewed tobacco, we might get really keratinized layer, which sometimes does not, the basement membrane invasion is not particularly seen, and hence cannot be labeled as a invasive.
So mostly verrucous and proliferative lesions, right?
Yes, sir. So in those cases, I think incisional biopsy would definitely be more beneficial.
So shall I just put across to the panel that, you know, there is no role for a scrape or a smear or a brush biopsy. You would all go for an incision biopsy in this case. And if possible, you would go for a deep biopsy, because in many of these verrucous lesions, in order to show invasion, you really have to go deep down to the basement membrane. Shall we take that message across?
Yes, sir. I think that's
yeah. And if you have to repeat, Dr. Dushyant, how many times would you repeat? Because, you know, going in for a surgery with a non-conclusive report is actually a pain for you and for the patient as well. Isn't it always better that you are both on the same plane? Mein cancer ke liye operate karne ja raha hu. So
Exactly.
would you do a repeat, and how many times?
No, exactly, Arun. If my pathologist says that I have adequate tissue, that it is not a tissue depleted biopsy, they are able to see the basement membrane in the tissue. I will not repeat the biopsy. I will explain my patient that this is a highly suspicious cancer-looking lesion. I will like to go in and operate you just like we do for the cancer, and we will wait for the final histopathology report and act accordingly. So I will counsel my patient in that front.
Any other way of handling these from the surgeon's team? Dr. Shenoy, are you there now? Are you all? Let us all agree with Dushyant.
Yes, definitely, sir.
Let's all agree. So that's a great message that has gone through from this slide. Number one, no smears, no brushes. Go in for a proper incisional biopsy from a clinically relevant area which you think is clinically suspicious. I don't think we rely on any visual aid for this biopsy. It's a clinical sense. So I think I put in pictures of fluorescence, and there is the blue dye, toluidine blue, which we use. I think it is not used anymore. I think we just go with a clinical sense. And if at all you have to repeat it, as Dushyant says, if you think your pathologist, the communication with your pathologist is important. If he or she has got an adequate tissue, and taking more is not going to help, no. But if it's a superficial biopsy, it's worth going in one more time, because it's always good if your patient and you are both convinced that you are dealing with surgery. So with that, so let's proceed. So what we usually do in such situations, there's a different patient, just to show the punch biopsy. So the punch has got a very sharp cutting edge, and if at all it's a superficial biopsy, we would go deep and core out a tissue, so that will maintain the relationship between the different layers of the mucosa. If possible, we'll get some deep tissue to show in the invasion. But the problem with these punches is that, like this tumor, if the most important, the most suspicious looking area is on the alveolus, you can't use these punches. Another problem with these punches are when you go deep, you hit one of the vessels, and many a times you just put in a little cotton swab and ask the patient to wait in the OPD and the bleeding stops. Here you may have to either cauterize it or even put a suture. So in a busy center, that may call for some resources of time. And it is now recommended that if you sometimes, you know, when the pathologist processes this tissue, they cut it at a tangent, and these tangential cuts, you may not capture the basement membrane invasion. So it's now advised that you put it over a piece of filter paper, and then you put the whole thing into formalin. So these are some of the changes. We do get a lot of these sort of cancers which look malignant, but it's never ever corroborated by pathology. And we try to get as much information from the little bit of tissue that we send down to pathology. So thank you so much. So now that we do a repeat biopsy, right? So the biopsy comes as a well-differentiated squamous cell carcinoma. So we are now ready to treat the patient. How do we proceed with the investigation? I have given you a list of investigations. So we did a repeat biopsy here, and it did come positive for you. As far as imaging goes, again, surgeon's role here. What do you usually send for a patient with a lesion like that? Dr. Ratan?
Yeah, I would order a contrast and a MRI scan because this is a tongue lesion. So
it's an alveolus lesion. It's an alveolus.
Now it's an alveolus.
Abutting
Okay.
onto the alveolus.
Then I'd order a CT contrast and a CT scan to assess the extent of the tumor and also to assess the image.
So, Dr. Dushyant, how do we usually, I agree with Dr. Ratan that he is going for a CT. So what is the decision-making process going on in your brain when a patient like this comes, CT or MRI? Dr. Dushyant, how do you decide?
Yeah, so usually CT scan is better for the lesions which are near to bone. And if you want to see enhanced soft tissue details like tongue or floor mouth lesions, then MRI is a better choice. In alveolus, we will like to see extent of the tumor as well as the bony involvement. So CT is a better choice at that. While in MRI, we want soft tissue delineation more. So MRI is better choice in soft tissue like tongue.
Right. So the role of imaging is to assess the extent of the disease, see its relationship with the bone, because that would impact the way you operate on these patients. And the patient is N0 clinically, but you would also want to assess the neck. And a CT scan with a contrast would be a good tool to assess the neck. But anyway, you would be going in for a neck dissection in this case, in a proven malignancy. But it will give you the status of the neck as well. So what about metastasis? In an N0 neck, the possibility of a lung mets, it's really low. So would you do a CT chest or an X-ray in this patient? I'm missing Dr. Shenoy here. Like, is there a technical glitch? Because I saw him sometime earlier. Or is he not joining? Okay, we'll continue. So Dr. Arjun?
Yeah, I think for a minimal, I will get a X-ray chest. It is an early lesion and the likelihood of distant metastasis, especially to the lung, is very, very low.
Right.
But just to be safe, I will get a chest X-ray at least.
Right. We all agree. Any difference of opinion from my surgeon colleagues?
I agree with Arjun, as well as when you are going for a CT scan up to the base of the neck, up to the clavicle, they can just extend it down and take a CT thorax also at the same time. So if one investigation is serving both the things, no problem in that.
But you need to have a very compliant radiologist to do that. They usually don't do that. They said, that's a different investigation altogether. But I agree that, a chest without an N0 neck with a very early superficial tumor, we would not go for that. But rather, if it was a more advanced tumor, if there was bone erosion, if there were nodes, especially in the neck, I think I would go in for a CT thorax to exclude a metastasis before we go in to do any kind of an extensive surgery in these patients. Is it okay? Will you accept that argument?
Agree.
So we will proceed with that. So that's it. And this is the CTs that came with that. So we have two windows here. This is the one with the contrast. You could see the vessels all glowing up. And you see this is the buccal mucosa tumor abutting onto the mandible. But the cortex is intact. So there is no bone erosion anywhere. How are we going to treat that? I think we'll have the surgeons coming in once again. So Dr. Ratan, what would be your management? So this is T2 clinically, abutting the mandible, no paramandibular spread, and no nodes in the neck, and no bone erosion.
Like to assess. Yeah, I'd like to assess the extent of paramandibular spread.
No, I tell you why I haven't put the coronal scans. That good question. That is another indication for taking down the bone, even if there is no erosion. But here I haven't put in the coronal scans, but there is enough bone height which you can get. There is no paramandibular.
This is a primary alveolar disease, and there is no bone erosion as such. So it is safe enough to do a marginal mandibulectomy with adequate margins all around and do an appropriate reconstruction.
Right. And now comes the bigger issue. So do we all agree that, if there is no frank bone erosion, there is no paramandibular spread, a limited disease, in spite of it being multifocal, we can still remain conservative? Hi, Dr. Shonai, we were missing you. Shonai, sir. We can't hear you. You need to jack up your volume. Okay, go ahead. We all agree, yeah, it's
We can't.
Okay, we'll move on. So, Dr. Vipin, so how do you usually reconstruct your marginal mandibles? Your surgeon has done a marginal mandible. Most of the time they would do the reconstruction, I'm sure, with a small defect. But from a plastic surgeon's perspective, what would you usually do for a marginal mandible with a neck dissection?
If there is a significant defect, sir, then radial artery forearm is one of the best options.
Right. So you would go to a free flap straight away, right?
No, if there is a significant defect, yes. And I can usually, I mean, whatever type of reconstruction you are going to have, you should have a backup plan. So I can keep a loco-regional flap option as a backup plan. I think this is a female patient.
42-year-old. 42-year-old lady housewife.
Yeah. So submental, if the defect is small, then we can go think of a submental or a supraclavicular flap.
Dr. Dushyant, you're quite fond of local flaps. You know, requires a lot of ingenuity and creativity to get it in. Rather than free flaps, you know, you can tailor it to the defect. So what are the kind of common soft tissue local flaps? Because this discussion is on local procedures for head neck.
Yes.
Yeah, Dr. Arun, first and foremost, have we done an intraoral marginal mandibulectomy or not? That may enhance our armamentarium. If it's an intraoral marginal mandibulectomy, most probably you do not have an oro neck communication. So if you have a good floor mouth tissue with you, because this was an outer BA sulcus tumor, then you can just advance your floor mouth, cover your mucosa, and that will suffice. That is one thing.
Right.
Second is that skin graft with bolster in that area is also good, because we are most probably dealing with a T1, T2, and 0 tumor. Most probably we will not require an adjuvant treatment, and a good uptake of the skin graft at that area will help us. Third is that we can use nasolabial flap here.
Yes, nasolabial is a good
option.
option.
It inside if that nasolabial skin is good, and we can do that reconstruction with nasolabial also. So there are multiple options which we have. Submental flap, I am not very comfortable, though they say that it level 1A and 1B are negative, you can safely use it. But in an BA sulcus, lower BA sulcus tumor, though it is an clinically N0 neck, I will be a bit hesitant to use submental flap. Yeah.
Okay, so great. So we have now, you know, from our panel, we have got some very sort of, you know, clear ideas of how a marginal could be reconstructed, right from just mucosal advancement to a skin graft, to a local flap, to a free flap. So again, the message that goes out here is that you need not remove the mandible every time. You can leave bone behind, which greatly improves function and cosmesis. If there is no paramandibular extension, if the patient has not been radiated before, you can leave an adequate stump of about 1 centimeter from the lower border. You would be able to get away with a marginal mandible. So one of the biggest mistakes I used to make at one point was to get this, you know, cut like sharp, because this is an area where pressure would slowly sort of form and the patient starts chewing, and you may anticipate a fracture at this point. So now please make it smooth and as rounded as possible. This is from a different patient. Here we did an intraoral excision. So how did marginal evolve? But at a time when oral surgery first started in the 50s, people believed that the lymphatics ran along the mandible. So it was Marchetta who first showed that you need not remove the entire mandible. You may very well preserve it. And Brown again showed that the pattern of spread may be very different. In an edentulous patient where the tumor is lying almost flush with the upper surface of the bone, it may enter through the attached gingiva. But in a dentate patient, it may even find its way from the point of contact, and there's another path through the periodontal ligament and into the bone. So a lot of studies have been done on that. And again, it does not affect prognosis. So this is from Australia, Chris O'Brien, is that marginal mandibulectomy does not affect outcome. Even, you are not able to truly assess the extent of disease, and you found that the bone margin is free, even if it is involved, but you can get a margin on the bone. Now, this is a very contentious issue. Dr. Shenoy, how do we know that a margin is free in a bone?
I don't believe that you can get that information intraoperatively because frozen section cannot be done on bone.
Excellent.
However, having said that, what you can do is go to the periodontal, the reflection of the periodontal membrane or the mucosa over the cortex, and send that part. And that is very important. You ink that part and send it to the pathologist so that they will take the representative part to get some message across to the surgeon.
Right. Dr. Shetty, any idea? Do you do anything to find out your bone is free after doing a marginal, or you're happy with your soft tissue margins? Because many a times the disease fails not because of the bone margin being positive, because your soft tissue margin is positive. But do you make any efforts to find out whether your bone margin is free?
My decision regarding whether to do marginal or a segmental is preoperative, not intraoperative. So if I find that there is bone loss on imaging, it is safer to do a segmental mandibulectomy rather than a marginal mandibulectomy.
Right.
So my decision is done preoperative, not intraoperative, because there is no real way of knowing whether the margins are negative or not, because frozen next to us, frozen cannot be done on bone. We can send the marrow sampling, but these are very accurate.
Dr. Dushyant, anything like imprint cytology or anything you try to find out? Are you worried usually with a bone margin? No, it's okay. Once you have done your assessment on CT, you're good to go.
The thing is that when you are going for a marginal mandibulectomy, almost you are sure that you are going to get it. There are certain places where you are in doubt. Sometimes what happens that there is an removal of teeth and there is an enhancement in the marrow, but your tumor is actually not going there. But you are really worried that when you are cutting, it is your tumor or it is just an enhancement of inflammation. At that time, when we are in doubt, we send scooped out marrow from the patient side for frozen section. And our pathologist can tell us that this marrow is involved or not. So that gives us assurance.
Great point. Dr. Prathamesh, I think you are there. I remember having had a discussion with you on this. And Dr. Prathamesh had a very bright idea. He said, we can just sort of drill that area, get some bone dust and send it for a quick analysis. Prathamesh, any sort of, that was a great tool. Have you made any progress on that yet?
Yeah, Arun, we have done a study and we looked at the bone dust. So we collected the bone dust from the bed of the tumor, from the edges and at the margins, which we have predetermined. And what we found that we could actually identify atypical cells, which would highlight the possibility of a disease process, which you might then consider taking a wider margin. But I feel that in a patient who has no bone involvement, your margins are usually predetermined on the imaging and the extent of the soft tissue. And as you rightly said, and as most of the panelists agree, the failure is usually the soft tissue. So I feel more information needs to be ascertained. If you are in doubt whether the bone is involved, you might even consider using an MRI as a decision-making or a troubleshooting tool, and then make a predetermined, bone cut. But as we discussed, the bone dust is still being under clinical trials, and maybe once we are able to prove that it is a useful tool in the frozen section, we are going to come out with a publication mostly at the end of this year.
Thank you. Thank you for, I think I would just sum up this discussion here. The decision to go for marginal cannot be done on table. You have to go through your imaging to decide on the extent of your resection. Various techniques have been tried, like scooping out marrow and sending it for examination, getting bone dust. We used to send smear, like, just imprint cytology from the exposed bone, just put in a slide, press it onto that and send it over. But the biggest worry here was that, maybe there could be cells which have sort of separated out from the tumor during the process and contaminating the field, and that could be interpreted as positive by the pathologist. But again, I think as Prathamesh put it very clearly, most of the time marginals fail not because of the bone being positive, because you haven't got an adequate soft tissue. Dr. Shenoy, anything to add?
Yeah, I have a point. I would also ask you, when you're doing marginal mandibulectomy, to send the nerve margin from the mental nerve and also the posterior, while the anterior superior dental nerve enters the lingula. If that is also included in the posterior part of the margin, for instance, when you're including the coronoid process for a posteriorly based lesion, I think that should also be included, because it will give you some information in the final pathology, not immediate pathology, but it's a good idea to send the mental nerve and proximally and distally as it becomes a part of the mandibular nerve. So I think
you're worried about perineural invasion, sir?
Perineural, absolutely.
Okay, got it. Thank you, sir. So again, margins free. It's quite big. It is like more than 2 centimeters, margins free. So no nodes were all negative, but there is a focal cortical bone erosion and there is an increased depth. Here we need your help. Dr. Mohanty, please come in. So does focal cortical bone erosion matter in the staging, and would you treat this patient for depth alone because it's T2, not yet 4 centimeters. The nodes are all negative, but 7 mm depth. Dr. Mohanty, can you hear us?
Yes, I'm able to hear you. Good evening to all of you.
Thank you, sir. Thank you for joining. Great to have you with us.
Okay, my pleasure to be here with all of you. And I'm learning quite a lot. So we are talking about two things. One is the focal cortical bone erosion. The other is depth of invasion. And we are talking about depth of invasion above 5 millimeter. So my request to the surgeons will be, will they refer the patient to a radiation oncologist or not? Because
so we would sit at an MDT usually.
And because you are the gatekeeper, because I saw a chat that from one of the panelists that let us keep the PORT reserved. So I want to know from the surgical colleagues, will you refer to the radiation oncologist to evaluate or not?
This is a googly, Dr. Mohanty. I would, when I have somebody like Mohanty in my panel, I'll certainly use his expertise and take some inputs. I think I would do that.
Dr. Mohanty, he wants to make it in an MDT, and all the surgeons are looking at you now. So how would you do?
No, my request will be that
I would say, the patient is scared. He wants radiation. What do we do?
Yeah. Okay. My requests are on 2 points. One is that we have realized that the radiation therapy utilization rate for head and neck oncology in the low and middle income countries are much lower than what is optimal. That is number one. That happens because the surgeons and the dentists are reluctant to refer the patient to radiation oncologist to evaluate. That's number one. For this case, in instance, I would say that because of the age of the patient and because of the depth of the invasion and having a marginal mandibulectomy, doing a very focal post-operative radiotherapy bed will not anyway compromise the outcome or the oral physiology of the patient. So my request will be that not to keep it in reserve, but to give the post-operative radiotherapy.
Dr. Aparna, do you share that view?
Yeah,
this would actually be a T3 if it is HSAC 8, because
Yes.
it's an old slide. This is HSAC 7 is T2, but this would get upstaged because of the depth. So
because T2 with more than 5 millimeter makes it T3.
T3. It makes it T3. I'm sorry, it's an old slide, so that's why it's a T3. It's HSAC 8 would be a T3.
HSAC 8th edition, it makes it T3.
So would you radiate, Dr. Aparna, for one factor, just 7 mm depth?
Yeah, because it is the risk of local recurrence will be there, and I would also look for other factors like LVI, worse pattern of invasion.
None. So I've already negative, no adverse pathologic features.
But even the depth
is there. But depth is already incorporated into the HSAC 8, so it makes it T3. So have you all changed practice? We are all radiating small with little more than 5 millimeters depth. What is your practice, Dr. Dushyant?
Yeah, particularly because the tongue and the floor of mouth, these are the lesions where we give adjuvant radiotherapy, even in T1N0 when the depth of invasion is more than 4 mm.
In buccal, ma'am?
In buccal mucosa, if it is well differentiated, margins clear, T2N0 we can observe. But in tongue and floor of mouth, we definitely go for adjuvant radiotherapy.
Yeah, I have one question for Dr. Mohanty. If he is going to irradiate, would he irradiate only the primary, or since your neck dissection is free of any deposits, and I assume that your pathologist has done a thorough job, if that is the situation, will he irradiate only the primary and leave out the neck? I want Dr. Aparna and Dr. Mohanty to give a...
So it's like this. No, I think Dr. Aparna wants to say. Please go ahead. Please go ahead.
Oh, sorry, sir, you can go ahead. But just I want to say depth of invasion is the prognostic risk factor for the neck involvement, recurrence in the neck. So we go for the up to level 4, and we will go, the dose will be different. Like we will go up to 50 gray for the ipsilateral neck, level 1 to level 4. And then to the tumor bed, we go up to 54 to 60 gray.
No, but are you going to, since he has dissected the neck and you have not had any positive deposit there?
Yeah, because there are various studies which says that there may be some the chances of neck recurrence are more even if after the neck dissection.
Right. So I think I can understand that there is a lot of heterogeneity in the way we are thinking about it. For the first time, HSAC has brought in a pathological factor into the staging. We used to consider the multiple sort of adverse factors, and the practice in most centers was not to give radiotherapy for one isolated feature. Usually would take in a collection of either 2 or 3 adverse factors that varied from department to department. But HSAC brought in this depth. And when it is a sole factor, it actually upstages the disease to T3, forcing many people to give radiation for that. So of all the risk factors, depth suddenly took predominance. It has become a very major factor. So I do understand, and that's precisely the reason why I wanted to put this issue here. So I'm sure the house would be very divided on this. Many centers would give it radiotherapy being T3. Many centers would still consider it to be a minor factor in the absence of nodes, and all other pathological factors may well go without radiotherapy. So I guess quickly, so how many would radiate? So Dr. Shenoy, what do you believe? Would you give radiation? Would you send the patient like Dr. Mohanty wanted you to send the patient to him? So would you send the patient for radiotherapy?
Yes, no? I don't think I will.
No.
I will take his opinion, but I will not.
Dr. Dushan?
If I am really sure about my surgical resections, my margins are wide away, I will not send him.
Dr. Arjun Singh?
Yeah, I agree with Dr. Dushant. I don't think
Dr. Ratan?
I also would not radiate.
Wow, lovely. So that's great. So even if HSCC calls it 8, we are still reluctant to treat this as T3, which would be a locally advanced disease. So thank you for that message. Now, is cortical bone erosion ominous? Has it caused any change in the staging? No.
Dr. Arun, for alveolar tumor or for a buccal mucosa tumor?
This is a buccal. This is a buccal tumor.
For a buccal tumor, a cortical erosion is bad. For alveolar tumor, the staging changes.
Right. Yeah, but this is in the lower alveolus.
So if it is a BS sulcus going to cortical bone and there is a cortical bone erosion, it becomes T4.
Okay. All right. So so when would you give adjuvant? Radiation oncologist on the panel. So of all these, how do you decide when to give radiation? So there are so many adverse factors other than depth. So would you choose one, two, many, any? What is your rule, Dr. Aparna? How would you choose? Quickly, if you can just sort of tell us how we go.
I think we have some clear-cut indications, margins, close margins, positive margins. You would go for concurrent chemoradiotherapy as well, but only radiotherapy would be margins, nodes. And
anyone, would you send anyone, or do you think is eligible for that, or do you use a bouquet? You do use a combination of factors to decide?
I think if there is one, I think it definitely makes sense to go ahead because
yeah, and there are many emerging ones like WPOI is emerging, lymphocytic infiltrate is coming. So the lot on the horizon. There are many more minor factors which are going to make their way into our staging systems.
We are actually having a trial ongoing, sir, at Tata Memorial, and it's a multi-center trial, it's the ARREST trial,
right,
which is looking at the soft indicators for prescribing adjuvant therapy for early oral cancer.
Yeah, so thank you for highlighting that, because that issue is still unresolved, and very rightly said, we would need a good prospective trial from a country like us. We would treat a lot of oral cancers to decide on small early cancers. When do they need adjuvant radiotherapy, or whether they benefit from whether they give it to a 1 factor, 2 factor, or multiple factors. Let's now come to Dr. Srinivasan. Srini, we need your help here, man. So we heard our surgeons and we heard our reconstructive surgeons that, there are various ways of reconstructing a marginal defect. The first picture would be a radial forearm, and the next one is the skin there. If it was left, the choice was left to you, and the surgeon said, I am open to whatever you tell me, Dr. Srinivasan. What would you tell the surgeon? What kind of reconstruction would you prefer as a prosthodontist?
Yes, thank you, sir, for getting us our specialty also on board. Now here, sir, a lot of it depends upon the initial plan. So I think being a part of the discussions initially with the entire team becomes paramount, because these decisions can be interrelated. Now, as you rightly mentioned here, if you're contemplating a bulky flap there, it definitely needs to be debulked before you go in for any kind of prosthetics. Now, if you have good enough number of teeth to be able to anchor a prosthesis, you need not always be contemplating implants for rehabilitation. You could seriously consider removable prosthesis as well if you have good number of teeth. And especially as we've already seen in the discussion, that a lot of decisions are ifs and buts. And when you don't have a clear-cut clarity on the path ahead, I think it could be very well safe to consider a removable prosthesis to start with in the early days, and then take those decisions on a case-to-case basis as you move ahead, if you would want to take, if you want to involve implants. Yeah. But if there is reasonable clarity on the path ahead, considering, for example, the age of the patient and otherwise, and prognosis and the at least an initial gut feel on the need for adjuvant radiation therapy, it is not it's not a bad idea to consider. I'm not saying to go ahead, but to consider even implants at an initial stage. It's not going to be easy because you are going to be placing the implants in the inferior border of the mandible, and you have the antagonistic dentition, which is a bit more medial. So you may end up prefer to place the implants a bit more lingually tilted than otherwise. Either ways, I think the choice of prosthesis in my book would be a removable prosthesis and never a fixed one, because maintenance becomes very difficult, and patients are generally sold out on fixed teeth, permanent solutions, they say. But I think we should all consider removable prosthesis very, very seriously in such situations.
So would a removable prosthesis sit on a boggy bed like a radial forearm, or maybe sort of a lateral sort of an infrahyoid flap? Do you think they need to be debulked before you can even give a removable prosthesis?
Absolutely, sir.
Pre-prosthetic surgery, right? You would recommend
absolutely, sir. Your bulky flap is never good for any kind of prosthesis, be it with implants or without it. So any soft tissue around implants is also not a good idea. So debulking the flap is always is going to be a good, probably a prerequisite, I would say, for any kind of prosthetic intervention.
But a marginal defect is very rehabilitable, if I can use that word, right? And every surgeon should try to get it done.
Definitely, sir. Definitely. I think it is definitely a good thing, even from a prosthetic standpoint, for an optimal rehabilitation with, for patients.
So you already cleared this issue. Yeah, go ahead.
Arun, I wanted to ask the question: how do you plan the implant if this patient is to receive post-operative radiation therapy?
Right. So Dushyant, sir, I think Dr. Dushyant very clearly said that if the patient had a node positive and he was going in for radiotherapy, he would not want an exposed bone there. Rather, a mucosal advancement or a skin graft would be lower down in his order of priority, and he would sort of put in a thicker, a bulkier flap, which would sort of vascularize that area better and prepare it for radiotherapy. So the picture.
No, what I'm saying is implant. The
implant, yes, Srini, this is a bugbear of all oncologists. They think that if you give radiate that little implant that you put in, they're likely to come out. So that is why Dr. Srinivasan, intra-op and delayed implants. How do you choose and why do you choose? And bring in the issue of radiotherapy, because many of these patients would be needing radiation. So would you put it before intra-op, or would you wait for the radiation therapy to be over?
So from a technical standpoint, I would say I think there are enough studies these days to suggest that the outcomes eventually, whether you place the implants at the time of immediately after primary resection and reconstruction, or at a delayed stages, are more or less equivalent. But what the advantage you derive by placing the implants early on is that you get a radiation-free environment of about 4 to 6 weeks, which you would never get ever later. And the vascularity is never really comes back to that stage ever once you give radiation therapy. So I would say it's a good idea to place the implants upfront. Yes, this is not a rule of thumb. I mean, if you've not been able to plan if you don't have preoperative planning done for your fibula, for example, so are you considering marginal mandibulectomy?
Marginal. We have a discussion on marginal here.
Only marginal, right? Yes, only for marginal. So I think here it's going to be predominantly unplanned. So I think if you feel you can get into the OT, but if you feel that you don't have enough stock of bone, don't place implants. I would say at least 12 to 15 millimeters of bone is good. 10 to 15, I think, is good. And either ways, if you're talking in the context of radiation therapy, I would still go ahead with place implants if possible, simply because the moment the tissues are irradiated, should they be, you would have to wait for at least 12 to 18 months before you re-enter. And in irradiated tissues, the more you try to play around with the tissues, I think you're just asking for
one more one more important question I have. If the patient has oral submucous fibrosis which precludes adequate mouth opening during the marginal mandibulectomy, at the end of the marginal mandibulectomy, will it change your decision?
Yes, it would. Because I would say then in that case, it's better to wait and watch and understand how how the patient's mouth opening is going to move, in what direction, and then go ahead. So if it's a case of oral submucous fibrosis, probably I wouldn't go in and place implants upfront.
Thank you.
I would probably prefer to wait and watch.
Dr. Vipin Barthwal, how quickly would you want a prosthodontist to go in and meddle with your free flap?
Sir, soft tissue flap. If you are not doing it in same sitting, you're asking that. Huh?
Yeah, or would you want him to do it in the same sitting? And
No,
are you comfortable doing it at that time, Srini? Enough bone height, all other things considered. They're putting in a free flap. Do you want to make a hole in it and put a implant at the same time?
Yeah. Definitely. That's my preference will be for a delayed implant reconstruction. Now, if radiation is not being done, so I think after 6 weeks, it's a good time.
6 weeks.
Yeah.
So you don't want it to be sort of punctured at that point when you insert it.
Yes, sir.
Srini, what do you say? If I'm a bold plastic surgeon, say, come ahead, go ahead, do it. I'm ready to take care of it. Would you do it at the same time?
Yes, if it's a free flap, and I think a lot of it depends on the kind of tuning you have and the way you've been able to work together. If you understand each other and you know where you're heading, I think placing implants at the time of primary reconstruction, in fact, saves the next surgery for the patient. But yes, a lot of it, I'm stressing on the word tuning and planning, because should you get the fibula wrong, then your implants are going to exit somewhere else.
Correct.
So I think
just a question, sir. Pertaining to the patient which we are discussing, this patient has a marginal mandibulectomy.
Yeah. This is a delay. That's a radial flap which you see, very thick radial flap there.
What happens in case of marginal mandibulectomy? Should we do it? I mean, as of now, I haven't seen being done at my institute the dental rehabilitation in the same stage.
Yeah.
Can it be, or should it be done?
We do it. We have done mostly on segmentals. We have got it to pass through. We have identified the perforators, and we make sure that we leave small fiducial markers there where the perforator is well preserved and protected, and then we do it at the same sitting.
In a free fibula. But what about marginal? What about marginal?
Marginal, we haven't had a choice. This is the first marginal that we did. It was a radial forearm, and this was done delayed. The patient didn't receive radiotherapy, so we have debulked. We have thinned it out. We have left the skin part of the flap on the bone, allowed it to, and then we have put in these implants. I think we had a very great discussion. We didn't go into many cases, but look at the challenge of a small marginal. It has taken us an hour to go through. So it was a very wide-ranging issues that were covered with this single case, and I'm afraid we will have to stop with this one case because I'm not going into the second one due to paucity of time. I must thank all my panelists. You did a great job. You put across a few very key messages, and I'm sure ICanCaRe is all about not about rehabilitation and putting the patient back on his feet, and nothing more than teamwork. Plastic surgeon, prosthodontists, oncosurgeons working together. It was really wonderful to get together on the same platform with all of you, and we continue this relationship in the operation theater and the clinic as well. So thank you so much for joining me.
Thank you. If we can have everyone to switch on the camera, then we can have a.
Pawan, I have some problem with my inbuilt camera. So you can do away with me.
Okay, sir. Yeah. So we'll just take a picture. I think if everyone can submit and all, if they can put on the camera. Yeah. Yeah, Sunanda.
So we just, yeah, I think Samit, if you're there, okay, we just had it. Thank you. So we have Dr. Handa for his expert comments, sir. Dr. Handa, please.
Yeah, this is a very, very informative panel, and Dr. Arun covered most of the aspects. The course of 50 minutes. There is always, regarding reconstruction, all cases where all flaps have to be done. How far should we go? Then the prosthodontist role and collaboration. So it has been brought up very well. Thank you very much.
Thank you, sir. Yeah. So Rishabh, over to you. So I think
I now request Dr. Prathamesh sir to please share the concluding remarks for the today's session.
I think we have had a wonderful session. We have been discussing about the various reconstruction options, early to intermediate advanced oral cancers by Dr. Mudit Agarwal. Dr. Johar discussed in a balanced view of various local flaps and free flaps in early oral cancers. There was a wonderful exposition of the role of sentinel node biopsy by Dr. Richa Mahajan and the context of management of neck. And we know that that is the way forward in reducing the morbidity following neck dissection. Dr. Vani Parmar, an accomplished breast surgeon, explained lucidly the basics of 3D printing, which is the future today. And I foresee that we will reduce not only the cost, but also tailor-make various prosthetics for our patients. Dr. Jyotsna Sheikh brought to fore the need for rehabilitation and the various concepts of prosthetics, which will enhance the quality of life of our patients. And finally, we had the wonderful panel by Dr. Arun, and he really brings about with passion the various aspects, truly true, though only a case was discussed, it was more than a case. And I think the key feature is the multidisciplinary approach that is required for even a small lesion, such as a buccal mucosa coming onto the mandible. What we realized was there's so much of discussion, not only on the treatment planning, but also on the rehabilitation. And today we need to focus all our attention to rehabilitating our patients. We have reached the pinnacle and the plateau of local control and distant control. So we need to focus all our attention towards a proper planning. And I need to take a page from Dr. Srinivasan, who has been so vocal about the need for a prosthodontist as an essential part of the treatment planning team. The latter half of the discussion, you must realize that after having done a marginal resection and removing the teeth of a patient, it is not enough. We need to rehabilitate them, and the focus of everybody's concern is which flap to do. It is only because we want to restore form and function. And truly, if you understand, in our large volume centers, 99% of patients will not go in for a dental rehabilitation with implants because they are so frustrated with the entire treatment, surgery, radiation. So the pre-treatment planning, the counseling of the patient at the first instance, that this is what you will require going ahead, is the key towards a very good quality of life. I thank the entire team at ICANN for this session, and the panel was really wonderful. Thank you very much.
Thanks, Dr. Prathamesh, and I'm sure now people have been waiting for the quiz, and that's the highlight for today. Also, again, the quiz is there, and we look forward for everyone to join in. And I would request our quiz leader for today, Dr. Dushan Mandlik, to take over, and please go ahead, Dr. Dushan. And we have the Harshadhar as a master. Over to Dr. Dushan.
So good evening, Dr. Pawan. This is the third quiz and there was a great participation in the first two quizzes, and a lot of good communication and good participation. Can we go to the instruction slides? Okay, so everybody will be muted.
Rishabh, you have to go to the instruction slide.
Yeah, instruction.
पहले वाला slide ले लो. Earlier, one slide earlier to this.
One slide earlier to this, please.
Rishabh, one slide earlier to this, please.
I think I'm lagging some issues.
You want me to share? Something wrong? Rishabh, you want me to share or something?
This one?
No, earlier than this, just the starting, the quiz slide uske baad wala. Okay, so yes, the quiz time. Okay. Dushan, are you there?
Yes, I am there. Can we have the next slide, please?
Yeah, okay.
So there are interesting prizes. There is a certificate from the organizing committee, and there are scholarships also for this tobacco seizures and specialist courses. The first person has 50%, second person has 40%, third has 30%, and fourth has 20% rates to the scholarship. And definitely there are special gift hampers and gift coupons also. Can we go to the next slide, please?
And that's the Certified Tobacco Cessation course, which has been introduced by ICanCaRe in collaboration in accreditation with Gujarat University, which Rishabh had already told about. So of course, we have Dr. Dushan Malik and Dr. Rashmi Shukla as the quiz leaders. So these are some of the which I think Dr. Dushan, please.
Yeah. So this quiz is conducted for the third day right now. And to win, you have to participate in all the 3 days in all the quiz. And the quizzes will be having 20 questions. Today's quiz will be on the theme of today. Today's quiz is prepared by Dr. Harsh. And points obtained for all the 3 days would be added to select the winners. In case the tie, the fastest time of submission of the total of the 3 days would be considered. And a winner would be the highest and fastest total of the 3 quiz. You can also see the results on the given links, and all winners will get certificates and scholarships for CTCS, and the top 3 gets the gift hampers. The winner can avail the scholarship in the next scheduled online CTCS course, and the decision by the organizers will be final and abiding, and all participants for the quiz will get the discount coupon. So today our quiz master is Dr. Harsh Dhar, who is consultant head and neck skull base surgeon. Today together, we were all there together, me and Harsh. I think he's at airport right now, Harsh.
Yes, sir. Yes, sir.
Yeah. So he is MSNCH head and neck oncosurgery as TMS Bombay, and visiting consultant head and neck surgeon as SSKM IPG MER Hospital Kolkata, and he has special interest in thyroid and skull base surgery, but he is an accomplished young head and neck surgeon. And I will hand over the quiz to him now.
Right,
Yes,
sir. Thank you so much, sir. Thank you for the organizers to give me this opportunity. So right at the outset, I'll just read out the instructions for candidates. You will get a link that is to be shared in the chat box. Participants need to open the given link. Please fill in your email, your name first, so that your response can be properly recorded along with the name. Start answering the questions, and after we share in the chat box, I think all the link on the chat box will be further disabled. So once you start answering the questions, you will have a total time of the 10 minutes to answer all the 20 questions. So we will keep reading out the questions to you on the screen as they come. And at the end of the 10 minutes, you have to submit, because you will not be able to submit it once the 10 minutes are over. Right? So please enter all the relevant details so that we can identify you correctly.
Rishabh, are you sharing the link here? Yeah, so that's there. So the link has been shared on the chat box. Everyone is requested to click on the link and you will reach to the Google page. Right?
Sir, I'm sorry if there is some background noise on my side. I hope I'm audible.
You are audible, Harsh. You are audible.
Thank you, sir. Thank you, sir.
If you can only, absolutely fine. Yeah. So
Right,
I think we go ahead. If someone can put here that you have been able to go to the link. Yeah, it's done. It to the page. Whichever link you choose, the two links have been shared. It goes to the same page.
Right.
Yeah. So we go to the next slide. Yeah. Okay.
Yeah, so everyone, please enter the email, your mobile number, your name, the institute where you hail from, the city, and your occupation or specialization.
We are just taking a few seconds to do that.
Yes, sir.
I hope it's done. So we are going to the question.
Right. So everyone, welcome to the quiz time. All the best to everyone. No Googling, please. Right. So question number 1, which of the following are true about the melolabial flap? Option A, very good option for alar defects. B, can only be superiorly based. C, can only be inferiorly based. D, have the best for match for skin at the dorsum of the nose. And E, cannot be used as advancement flaps. Please remember, you have to say which of the following is true. Right. So we go to question number 2. It's a slightly long question. Which statement best describes reconstructive and rehabilitative goals in PNS cancers? A, although functional rehabilitation is important following surgical removal of PNS tumors, aesthetic results take precedence. B, it is essential to obliterate the maxillary sinus space following a total maxillectomy for optimal functional and cosmetic outcomes. C, often a stage-free tissue transfer procedure to separate intracranial cavity from aerodactyl tract is preferred to primary closure with local flaps to allow recognition of postoperative complications first 24 hours. Or D, rehabilitative after resection of venous tumors may be achieved with the dental prosthesis or reconstructive flaps, such as temporalis flap, with or without the inclusion of cranial bone, pedicled or microvascular free mycutaneous flaps, and cutaneous flaps. It's a long question, so can I request them to give another additional 15 seconds maybe for this question?
Yes,
we can,
sure.
Yeah,
Sure,
yeah.
Dr. Harsh. We should give some more.
Yeah. Please read through carefully. Each and every word is important in this question. One single word in the question can change the whole thing. Right, sir. Question number 3. Which will be the correct order of flaps as per the reconstruction ladder in order of increasing complexity? Regional flap, microvascular flap, primary closure, secondary intention. Secondary intention followed by primary closure, followed by regional flap, followed by microvascular flap. Regional flap followed by secondary intention, followed by primary closure, followed by microvascular flap. Or option D, primary closure followed by microvascular flap, followed by regional flap and secondary intention. So the question is as per order of increasing complexity. This is the reconstructive ladder, components of the reconstructive ladder, which you should all know about. It is the basic thing we learn in when we start reading about plastic reconstruction. Right. Question number 4. Which one is not a transposition flap? Rhombic flap, bilobed flap, C, node flap, D is dorsal nasal flap, or E, Z-plasty. I repeat, which is not a transposition flap? Rhombic, bilobed, root flap. Yeah. Question number 5. Question number 5. The blood supply to parascapular flap is A, dorsal scapular artery, B, shared between parascapular flap and lateral dorsal flap, is not distinct from serratus anterior flap, D, runs between teres major and minor muscles, E, from the angular branch of thoracodorsal artery. Slightly difficult question because it's not a very commonly used flap. That is the gold medal question here. Question number 6. All the following are true regarding free fibular osteotomy flap for mandible defect, except A, a length of up to 20 to 25 centimeter can be harvested. B, multiple osteotomies can be performed to contour the bone segment according to the mandibular defect. C, there is minimal morbidity in terms of weight bearing and movement after harvesting a free fibular graft. D, adequate amount of soft tissue is available along with the skin paddle for reconstructing soft tissue defects. Question 7. Which vein is not a reliable recipient for a free flap? External jugular vein, internal jugular vein, C, facial vein, D, anterior jugular vein, E, middle thyroid vein. I repeat, which vein is not a reliable recipient for a free flap? Question number 8. Which is true regarding the deltopectoral flap? The donor side can be closed primarily. Preferred choice for pharyngeal reconstruction. Blood supply is from maxillary artery. D, should be raised as a musculocutaneous flap to preserve blood supply. D, distal end of the flap has the most robust blood supply. Question number 9. Which is true regarding the palatal island flap? Pedicle is from facial artery, option A. Option B, blood supply from both sides must be preserved. C, blood supply is from greater palatine artery. D, blood supply is from the lesser palatine artery. E, donor side has to be closed primarily. Question number 10. Which vessel is the most common choice for microvascular anastomosis in the neck? Superior thyroid artery, B, facial artery, C, lingual artery, D, transverse cervical artery, E, occipital artery. The question is most common choice. Question 11, and we are at the halfway mark. Which of the following are true about advancement flaps? Works better in areas in skin with less elasticity, have the greatest tension perpendicular to the proximal border of the flap, that is the base. Not a good option for cheek defects, works well in dorsal nasal defects, are very good option for forehead defects. Question 12, you have to look at this picture and you have to give us what will be the classification of this bony defect. The dark area is the bony defect as per the James Brown classification of mandibular defects. This was published recently in Lancet 2 years back. So 1, type 3, type 4B or 4C. Question 13. Which flap is most ideal for reconstruction of large full thickness scalp defects? Anterolateral thigh flap, latissimus dorsi flap with skin graft, lower trapezius island flap, vertical rectus abdominis musculocutaneous flap, and E, parascapular flap. Which flap is most ideal for reconstruction of large full thickness scalp defects? A small hint, you have to think about the reach of the flap. Question 14. Blood supply to the temporoparietal facial flap. Internal maxillary artery, B, deep temporal artery, C, supraorbital artery, D, superficial temporal artery, E, posterior auricular artery. The question is temporoparietal facial flap. Question 15. All the following are true regarding pectoralis major myocutaneous flap except it is based on a branch of the thoracoacromial artery. B, transposition of the flap is limited by the arc of rotation of the pedicle over the clavicle. C, it can be used to reconstruct scalp defects. D, the most distal aspect of the skin paddle is the most poorly perfused. And E, gravity may cause superior dehiscence of flap. Question 16. The following are prerequisites for rehabilitation using an obturator after maxillary defects except Defect should ideally not be more than category 2B as per modified James Bond classification. B, there should be a posterior shelf of soft palate so as to minimize nasal regurgitation. C, the patient should have adequate mouth opening to enable measurement of defect and placement of prosthesis. D, the opposite upper alveolus should be edentulous. So which are prerequisites except question 17. A full thickness defect of the upper lip not involving the philtrum and measuring less than 1/4 of the lip width should be closed. A, with a peri-alar crescentric flap. B, with peri-alar crescentric flaps combined with an Abbey flap. C, with an Eslander flap. D, with a Karapanzik flap. E, primary closure can be done. Question 18. Which of the following is an important contraindication for performing a submental flap? Size of the defect should be less than 5 cm in largest diameter. There should be a good arc of rotation from the donor side to the defect. The venous drainage of the flap should be into the internal jugular system. Presence of clinico-radiologically positive nodes at level 1A, which is an important contraindication. Question 19. Free flap reconstruction for head and neck surgery is contraindicated in A, diabetes mellitus, B, sickle cell disease, C, systemic lupus erythematosus, D, peripheral vascular disease. Question is free flap contraindicated in. So we are at the last question, number 20. The purpose of a guide bite or a guide plane prosthesis for mandibular rehabilitation is to A, improve mouth opening, B, bear implants for dentition, C, prevent deviation of the remnant mandible after flap reconstruction and improve occlusion, D, improve speech. So the question is purpose of a guide bite prosthesis for mandibular rehabilitation. That was the last question. Sir, do we give them 1 more minute to mop up? Right. Do we have one more question? Yes.
We have got 3 compulsory questions.
Yes, sir. So this is, would you practice oral screening and tobacco counseling in your routine after this workshop? So there are your options. Yes, no. I want to start ICanCaRe tobacco wellness and oral screening center, or I want to get trained in tobacco intervention. Compulsory 2. TrisCare, the innovative mouth opening device for Christmas care made of POM material, which is unbreakable. Your sturdy mouth opening can measure the grading and improvement of mouth opening. You would like to order the same for your patient. So you can select whichever the options are there. Contact me if you want to order. Available in hospital pharmacy. You will ask a patient to purchase it online. Or no, I prefer the old age methodology. I don't think anybody would take that option after this course. Compulsory question 3 is certified tobacco cessation specialist course is the only comprehensive tobacco course in Gujarat University. I want to take the course and I want to refer my friend for the course. We could have another option here, sir, that both of us want to come to the course. Right. So we will be posting the answers soon. So I think it is time to submit the, or do you want to give them 1 more minute, sir?
Yeah. Just 1 more minute.
Yes, sir.
And I would request those who are just completing, let them go to this HTTPS Facebook page and join the I've just shared the link in the chat box. Please
Yes,
go
sir.
to the page and community page so that you are connected with us.
Yes, sir.
During the program or later on also.
Yeah.
And of course, there is something very special for everyone, those who are participating for the quiz. We are giving them a special discount on this TrisCare, right? So
right.
This TrisCare which is being used. So there is a claim your discount by applying discount code 25, and we'll be providing them with the emailers very soon. So you can claim just by being part of this quiz, you are still getting a prize. And of course, those who get good marks and they have submitted early, they will get what we call scholarships for the certified tobacco cessation specialist course, and of course for others and some gift hampers as well. So I'm sure everyone of you have enjoyed this. So if there are, we open it for discussion, and we have got quite senior people here. So anything that anyone wants to share, please feel free.
So I think it was an excellent session. With respect to really thank you for organizing this kind of an initiative and giving a lot of impetus to the youngsters to, get aware about tobacco cessation, not just tobacco cessation alone, but the proper guideline, evidence-based care for oral cancer. I think it is a wonderful thing.
Thank you, Harsh, and thank you for being the quiz master. And I'm sure you have put a little very twisted and a little difficult questions for the third day. But
yes,
who have been practicing, I'm sure they would. There is a lot of learning in that. Actually,
right,
in the question, there is a lot of learning. So
yes,
definitely, people would learn through the quiz also. So
right.
yes, we are coming to the end of the third day. So we have Dr. Arun. Are you there, Dr. Arun? For the last words. So we have got Dr. Shomesh. Dr. Shomesh, would you like to say something before we end today? Dr. Shomesh? Yes, sir.
Hi, Pawan. I think the sessions are getting better and better. And we have been able to add a lot of expertise into the different aspects of oral cancer management, the diagnosis, and understanding the different nuances, not just the broad guidelines. Today we looked at the deficiencies of HSAC T3 staging, and whether we can call it a deficiency, at least we've been able to highlight that there are certain things which are not really in black and white, and there are still gray areas despite the updated TNM staging, including the depth of invasion. And reconstruction and rehabilitation, we discussed in very great detail. And of course, a lot more needs to be discussed, because at the end of the day, it has to be a very personalized management. And unless we understand all the nuances and all the players are on board in the management of such cancers right from the beginning, we cannot really do a complete justice to the patient. So my great thanks to all the participants, all the speakers, the panelists, and great job by Rishabh and his team under your leadership. And I think you keep on infusing the youngsters and driving them on the right path. I'm sure the tobacco cessation program at Gujarat University will get a boost from these sessions, and more people will join the bandwagon against the crusade against tobacco control, against tobacco usage. And that's the main thing which we are going to discuss in the last session a week later. So thank you, everyone, and great job, Rishabh and team.
Thank you so much. And definitely it was the last few words were really encouraging for everyone. And I'm sure the youngsters would try to get into this, the ICanCaRe Academy, which we are working for, and building, which is the most important. And the last day session is something very important for everyone to join in. So we welcome that. And the last word from our academic director, Dr. Reena. Over to you, Dr. Reena. And just in case those who are still here, yes, if you have not yet joined our ICanCaRe page, please do join the ICanCaRe page. Over to you, Dr. Reena. And then we close for the day. Ma'am, you are not audible, ma'am. You are not audible.
Better now?
Yeah, better.
Thank you, Dr. Pavan, for handing it over to me at the end. And Dr. Samesh, thank you. I echo and resonate every word that you said. And thank you for your good wishes and blessings. Yes, we will grow. I'm sure that, all of us together have really worked on to create awareness and regarding tobacco courses, and Gujarat University has stood by us. And we understand that the need of the hour is that every specialist has to come forward, not just in the management, but in the primary prevention, which is really tobacco as one of the major pinpoint causes. So we all need to work towards cessation, manpower skill up. The protocols needs to be standardized, and together we will always win. Thank you very much. And today's session has been amazing. I thank each and every one of our the panelists, the speakers, the quiz leader, and the moderators. Everybody has done a fantastic job, and the learnings which have come out are just so much to absorb that we really need to hold it so close to our heart. Thank you so much. Thank you, Doctor. Thank you, everybody. And more so, I thank all our viewers who have been with us through all these weeks and helping us to grow. Thank you.
Thank you. And we keep it open for just 3 minutes more in case anyone wants to say something or want to speak to the experts here. Yeah, Dipti. You can unmute. Anyone of you wants to say something? Dipti, Richa, they had been just interns with me just a few days back as a rotation. Dr. Shomit, if you would like to know that what we started was a training program for the dental people, and they come on rotation for 1 month with us. So that way, that Oral Oncology Connect program, that is an additional thing that we have started, that they have a hands-on practical training. So
I think we can get some inputs from the younger people. Kush, are you there?
Kush is.
Yes, sir. Yes, sir.
Yeah. So, what are your impressions? I mean, with these kind of programs, not just one-off session, but these. I mean, it's a string of sessions on a connected theme. This is very unique to the Oral Cancer Conclave, which we did last year and this year also. What are your impressions?
Definitely, sir. I agree to this concept that oral oncology is not a one-man's job. It's definitely a team job. During the course of these sessions, we have learned so many minute and finer details about oral oncology and how can we improve on the outcomes of the patient oncologically as well as functionally, which is more or less not discussed or not considered in surgical forums. So I would definitely like to take this forward with help of your seniors and all, that we can make efforts to make this oral oncology conclave teamwork, including head and neck surgical oncologist or head and neck oncologist, reconstructive surgeons, maxillofacial surgeons, prosthodontists, and also including scientists. I mean, this technology and 3D printing, which we learned today, we have miles to go, but it definitely has a role to play in the betterment of oral oncology in future. And I must say that the tobacco cessation program started by ICanCaRe is definitely very the eradication of tobacco from our community, and we all must work to even decrease this pandemic of tobacco which is prevalent in our country.
Thank you, Kush. And I think, Pawan, we can wind up for today.
Yeah, sure. I think, thank you so much. And I always can depend on you, sir. Thank you. Have a great day. Bye-bye.
Bye, sir. Bye.
Thank you, everyone. And meet next Sunday, the final session of the E-Conclave. Thank you so much, everyone. Have a great day.